you can. Recording का भी जरूरत है नहीं. You can start the recording at 7 p.m. Good. We can see. Can you make it full screen? Good. Very good. Joined on time. So today our virtual meeting is on, it's an update on retina, but we'll start from the basics and go on to the advanced treatments of the different retinal pathologies. I'm very grateful to all the national faculties who have joined. And without much ado, I'll move on to the first moderator of the session, Dr. Meha Kanta, who will be introducing the speakers. There's a short change in the sequence. The first paper will be by Dr. Pragati, and then we'll have the opening remarks by Dr. Lalit Verma. Dr. Meha Kanta, please.
Thank you, Satyaj sir. A very good evening to everyone. Though it's a very cold evening in Patna, I very warmly welcome everyone for attending this retina update organized by Bihar Ophthalmological Society. A very special welcome to our president, Dr. Pranav Ranjan, other esteemed boss dignitaries, and our highly reputed guest speakers who have given us their valuable time and graced us with their presence. So, as we all know, we're starting with we're going to wait for Dr. Lalit Verma's keynote talk, and we'll start with the second presentation. So we all know to understand any abnormality, understanding of the normal is very important. A thorough knowledge of the normal gives us a lot of insight in the pathogenesis of various diseases. So to refresh our knowledge on the retinal anatomy, I would like to call upon Dr. Pragati. Dr. Pragati did her MBBS from Indira Gandhi Institute of Medical Sciences, Patna, and is presently pursuing a post-graduation there. And to discuss this topic, I would like to call upon Dr. Vivek. He did his post-graduation from AIIMS and his senior residency there in the vitreoretinal department. And at present, he is the director and a VR consultant at Sarvadishti Eye Hospital, Patna. So, Dr. Pragati, so can we have your presentation now?
Dr. Meha, before she starts the presentation, can you call upon the chairpersons of the expert panel?
The chairperson,
please invite
Dr. Dr. Pranav Ranjan himself, Dr. Subhash Prasad, Dr. Soni Sinha, and Dr. Amit Raj. And we have an expert panel who constitutes of Dr. Shalok Sinha, Dr. Abhishek Anand, Dr. Siddharth Kumar, and Dr. Santosh Kumar. Pragati, you can start.
Good evening, everyone. Today I'm here to present on anatomy of retina. Human retina is a thin, delicate, multi-layered innermost layer of the eye that extends from the optic disc to the ora serrata, and its thickness reduces as we move towards the periphery. It is purplish red in color because of the presence of visual pigments. It is neuroectodermal in origin, and development occurs from the optic vesicle from the diencephalon, the outer layer of which forms the RPE, and the inner layer forms the neurosensory retina. Foveal development completes by 4 to 5 weeks after birth. Initially, retina is supplied by the hyaloid vasculature, that is an arterial system, and switches to the retinal vasculature in mid-gestation period, which is preceded by astrocyte migration over the retina from the optic nerve head. The various stages of development of retina is regulated by various genes, and mutations can cause conditions like anophthalmia, microphthalmia, coloboma, Leber congenital amaurosis. Retina can be divided into 3 distinct regions, that is the optic disc, macula lutea or the area centralis, and the peripheral retina. Optic disc is a pink, well-defined, vertically oval area, 3.4 mm nasal to the fovea. All layers terminate except the nerve fiber layer that continues as the optic nerve. It is a physiological blind spot because of absence of any photoreceptors, and it appears pale compared to the other parts of retina because of the lamina cribrosa and the medullated nerve fibers behind it, and absence of vascular choroid. Macula lutea is having a diameter of 5.5 millimeter, and it is present 2 disc diameters temporal to the disc and 0.8 mm inferior. Yellowish due to the xanthophyll pigments like lutein and zeaxanthin in the ganglion and bipolar cells. These are the pigments that has antioxidant properties and absorbs the blue light wavelength that could be damaging to the retina. Here we see the various parts of the macula. The outermost part, we have the perifovea, that is having the ganglion cell layer is multi-layered in this, becomes multi-layered in this area. Then we have the parafovea, that is 0.5 mm around the fovea, and the outer plexiform layer and the ganglion cell layer is the thickest. Inner to it is the fovea, that is having the cones as the photoreceptor cells only. The central depression is known as the foveola, that is around 0.35 millimeter in diameter, and it is having ganglion cell layer is absent, and the ophthalmologically visible light reflex is known as the umbo. Ora serrata is a watershed area between the anterior and posterior vascular system, so prone to peripheral retinal degeneration. Nasal ora is more anteriorly placed and serrated than the temporal ora, and its width is 2 mm temporally and 1 mm nasally. Dentate process is the extension of peripheral retina into the pars plana, and the scalloped edges of the pars plana between the dentate processes is known as oral base. Meridional folds are thickened retinal tissue in the peripheral retina that is generally having a retinal hole at its apex, and enclosed oral base are the pars plana enclosed by the retinal tissue. Equator is an imaginary line 14 to 15 mm from the limbus, and it is drawn through the ampulla of the vortex veins into which the choroidal veins drain. There are various cells in the retina that synapses with each other to form the layers of retina. Like the RPE cells, it has the apical part that interdigitates with the photoreceptor cells, and by the microvilli, and the basal part is attached to the Bruch's membrane by laminin, fibronectin, and type 4 collagen. Zonula occludens forms the tight junction between the adjacent cells, and it forms the outer blood retinal barrier. And there is in the basal part, we have the zonula adherence. The pigments present is melanin and lipofuscin that is variable in various areas and cells. And it is functions of RPE is absorption of light, regeneration of visual pigments, outer blood retinal barrier is formed by it, maintenance of subretinal space, and phagocytosis of the outer segment of photoreceptors. RPE cells in the foveal region is taller, thinner, and larger melanosomes are present that imparts the darker color to the macula. Here we have the rods and cones. Understanding the structure, there is the outer segment that has the membranous discs arranged stacked on each other, and from the tip it is shed that is phagocytosed by the RPE cells. These discs contain the visual pigments. Through the cilium, it is attached to the inner segment that has the ellipsoid zone containing the mitochondria and the myoid zone containing endoplasmic reticulum and Golgi bodies. Then by the outer fiber, it is connected to the cell nucleus that is present in the outer nuclear layer of the retina. And then it is inner fibers ends as the synaptic vesicle, and known as rod spherule in the case of rods, and cone pedicels. Rods are involved for scotopic vision, senses the brightness and contrast, and cones are for fine and spatial resolution and color vision. Bipolar cells are the second order neuron. Bipolar cells, the dendrites synapses with the photoreceptors and the horizontal cells, and the axons with the ganglion cells. And ganglion cells are the third order neuron in the visual pathway that synapses, the dendrites of which synapses with the bipolar and amacrine cells, and the axons continue as the non-myelinated nerve fiber layer. The horizontal cells has an inhibitory feedback to photoreceptors and the bipolar cells. The type A horizontal cells connects the rods of the various regions and cones of the various regions, and type B connects the rods. Amacrine cells have integrative function. Mueller cells is the major glial cell that extends from inner to external limiting membrane and provides nutritional and structural support to the retina. Here we have the various layers of the retina, where we can see that the pigment epithelium is having interdigitation with the photoreceptors in the layers of rods and cone. The outer limiting membrane is formed by the zonula adherence between the Mueller cells and the photoreceptors. Outer nuclear layer has the nucleus of the photoreceptors. Outer plexiform layer has the synapses between the photoreceptors, bipolar cells, and the horizontal cells. Then the inner nuclear layer has the nucleus of bipolar, Mueller, amacrine, and horizontal cells. Inner plexiform layer has the synapses shows between the ganglion cells, amacrine cells, and the bipolar cells. Ganglion cell layer has the ganglion cell that ends into the nerve fiber layers that moves towards the disc, and the inner limiting membrane is formed by the end feet of the Mueller cells. Here is the OCT diagram showing the various layers of the retina, which has various reflectivity that helps us to see the diseased part. Retinal pigment epithelium has the potential space between the RPE and the neurosensory retina is known as the subretinal space, and absence of junctional complex between the RPE cells and molecules like fibronectin and laminin makes it prone to detachment. Dysfunction of RPE can be seen in ARMD, retinitis pigmentosa, diabetic retinopathy, and CSCR. External limiting membrane is a metabolic barrier for large molecules that can also be called as the third blood retinal barrier. The outer nuclear layer in peripheral retina is the 3 to 4 layer of rod nuclei and single layer of cone nuclei. It is thickest at the fovea. The nerve fiber layer contains the axons of the ganglion cell, and the fibers from the macula go straight to the disc with the known as the papillomacular bundle. The superior and inferior fibers goes as superior and inferior arcuate fibers separated by the temporal raphe, and the nasal fibers goes as the directly to the disc with the superior and inferior radiating fiber. So in glaucoma, the arcuate fibers are affected, causing the glaucomatous arcuate visual field defect. Nerve fiber layer is thickest at the lateral and thinnest at supero and inferomedial quadrant of the disc. So in papilledema appears first at the thickest quadrant and last at the thinnest quadrant. Papillomacular bundle is present in most lateral quadrant and is most resistant to the glaucomatous changes. So the central vision is retained till last. Peripheral retinal nerves lies deep in the retina but is most lateral at the disc. In the optic disc, all other retinal layers are absent except the nerve fiber layer. In macula, it is rod-free and abundant cones. The ratio of cone, bipolar, and ganglion cell is 1:1:1. GCL is thickest and is known as Henle's layer, and GCL is absent in fovula but multi-layered in fovea. Ora serrata, RPE, and neurosensory retina continues as pigmented and non-pigmented epithelium of the ciliary body respectively. The retina has a dual blood supply. Outer 4 layers is supplied by the choriocapillaries, and inner 6 layers is supplied by the central retinal artery, that is a first branch of the ophthalmic artery, and it enters the optic disc and divides into the temporal and nasal branches, and it forms the vascular plexus, the superficial being in the nerve fiber layer and the deep one in the inner nuclear layer. The fovea is supplied by choriocapillaries because it is avascular and is the site of highest visual acuity because of minimum light scattering. Central retinal artery is in the optic nerve, has 6 layers of smooth muscle, and anterior to the lamina cribrosa has irregular arrangement of pericytes. It is an end artery. There is no internal elastic lamina, that is why that is not involved in temporal arteritis. Local autoregulation is there, and endothelium to pericyte ratio is 1:1, that is highest in the body. The cherry red spot at the fovea and CRO is due to visible choroidal circulation. In 30% of eyes, cilioretinal artery supplies the macula, and thus macula is spared in CRO. Retinal vessels gets 4% of total blood supply to the eye. The veins have a wider lumen than the arteries, and AV ratio is 2:3. The outer blood retinal barrier is formed by the zonula occludens between the adjacent RPE cells, and the inner blood retinal barrier is formed between the adjacent endothelial cells. Thank you.
Thank you, Dr. Prakti. That was extremely informative and comprehensive, and I'm sure it jogged everybody's memory. Dr. Vivek? Is Dr. Vivek there?
Yeah.
Yeah.
Hello. Hello.
Hello? Yeah.
Yeah. Am I audible?
Yes, you're audible.
Okay.
Would you like to add anything?
Yeah, actually, she has discussed the anatomy quite nicely, quite elaborately. Nothing much to discuss in retinal anatomy. But one thing I would like to say that it has profound importance in our practice. If you know your retinal anatomy very well, then only you can you can prognosticate diseases. You can tell that outer retinal diseases have poorer prognosis because visual pigments are there. Inner retinal diseases have a relatively better prognosis. One practical thing I will share with you all, which just happened to me. It will emphasize how important retinal anatomy is. See, actually, 6 months back or maybe 7 months back, I was going through an article on GRT, and the author has concluded that he has divided GRT in 2 groups. Basically, in one group, he has lasered the bare choroid area, and in another group, he has not lasered it. And he concluded that in the group in which he has lasered the bare choroid area, there was less of PVR. when I was going through this article, I was thinking, how is he able to laser their choroid? Because from our JR ship days, we have been taught that RP is essential for laser and all. And if you have poor RP function, laser uptake is poor, you are not able to laser. And we all struggle in myopics, so it impacts our mind. But recently I was doing a GRT and there was a large area of bare choroid. And when I tried lasering, to my surprise, the laser came. So I was not able to understand till then. Then I started thinking, and then it came to my mind that bare choroid is actually not there. RP's layer is still there. That comes from the knowledge of anatomy, because in retinal detachment, the inner 9 layers get separated and the outer layer is still attached. So you have to know anatomy to explain things. Otherwise, means it's very important. It's very important in day-to-day life. Thank you, and the rest of the things he has discussed quite elaborately. Thank you. Thanks a lot.
Thank you so much. So true. You don't know the abnormal if you don't know the normal. That's how it
Dr.
says.
Vivek, can I add just one point regarding this layering of this? The few of us also do what we do is that we just sweep with our flute cannula, we just sweep the RP cells. You can just wipe it out. Also, that has been also described. Yeah.
That has been described, but I was not able. I was not able to explain how laser came on there.
Yeah. Okay, I got that. Yeah.
Okay. So we'll proceed to our keynote talk. We all know that the wonder retina molecule, the anti-VEGFs, since their introduction in the field of ophthalmology, they have helped us to treat a myriad of retinal pathologies. And very true to the law of nature, this molecule has also seen developments over time to suit our needs better and more effectively. And to talk about these changing dynamics of anti-VEGFs, I would like to call upon Dr. Lalit Verma, sir. He needs no introduction, as we all know him to be a leading retina specialist and a pioneer in our field. He has worked over a decade in the RP Center, has over 150 publications in reputed journals, is a recipient of many prestigious awards. He has been an invited speaker for various conferences nationally and internationally. At present, he's working as a retina specialist in the Center for Sight, New Delhi. So I would like to call upon Sir for his keynote speech.
Thank you, Dr. Meha. I hope the slide is visible and I'm audible.
Yes, sir, you are.
So, wonderful talk by Pragati from RIO, because as I was discussing with President Pranav, that anatomy physiology forms the basis, and Vivek also rightly pointed out his observations about GRT and bare choroid. Very, very relevant points made by Vivek also. You see, other point I wanted to make about anatomy and this ARMD, because this session is primarily on macular degeneration, is that initial process of ARMD begins in the RPE, and it is the phagocytosis of the discs in the outer segments, which I think Dr. Pragati highlighted very nicely. And the best slide I liked in her presentation was where she had OCT on one side and layers of retina, because that is clinically most important and most relevant slide for every clinic. So I thank the entire BOS, all my friends there, specifically President Pranav Ranjan and Secretary Dr. Vibhuti, then all friends, Dr. Rajan, Dr. Subhash Prasad, and Nilesh, Nagesh, so many people I know of. It's like a homecoming once you attend any BOS meeting. So anti-VEGFs, you see, honestly have revolutionized everything. You see, I remember one of our renowned speakers is anti-VEGF has been more often misused rather than used in ophthalmology, and has become a favorite therapy for wet AMD, IPCV, and so many other conditions which are listed here. Even ROP is nowadays primarily being treated by anti-VEGFs. And he is the man, I think we should give credit, Napoleon Freire, way back in 1989, and his colleagues in Genentech. They were the first to clone VEGF. And this gentleman, nobody can forget. I recently had the proud privilege of sharing dice with him during one of the webinars. And this is Philip Rosenfield, who pioneered the usage of anti-VEGF, primarily bevacizumab in the beginning, and primarily systemic bevacizumab initially, and then intravitreal therapy, bevacizumab. So these two gentlemen, you see, are credited with both VEGF and anti-VEGF discoveries. And Macugen was the first anti-VEGF which got FDA approval. And after that came, Avastin, bevacizumab was being used, and ranibizumab came much later. And later on came the aflibercept. So this has been the chronology. Macugen, initially came with a big, promise, but believe me, the results of Macugen were similar to PDT kind. The graph always remained down and never went up. And in fact, in one of the conferences in DOS, I made the statement: Macugen is plain water, frankly speaking, and does not benefit these patients with macular degeneration. So these were the 3-4 VEGF inhibitors. And subsequently, so many trials, all of you are familiar with the trials with ranibizumab, Mirena, Anchor, Pyre, Pronto, Stellar, Excite, so many are there. Then with aflibercept, View 1, View 2. Then the recent kid on the block, I think there will be talks on this in the second session about Hawk and Harrier. Various anti-VEGF molecules and various treatment regimens, which confuses the entire subject, in fact. Monthly, treat and extend, PRN, Q8, Q12, so many terminologies we keep hearing. But there is always unmet need. You see, because trials give us, some indications, but the real world experience is totally different. And a lot of people discuss about what is the end point of treatment in ARMD and which fluid. You see, there's a big fluid debate and being pushed by various pharma companies also. You see, some people will say SRF you can tolerate, and some people say, all fluid is bad. We all agree IRF is the most, bad fluid, which there has to be zero tolerance for IRF. But I personally believe all fluid is bad. Just because you can't eradicate SRF by, agents, you tolerate. And a lot of literature is now available that some amount of SRF with stable visual acuity, very important is stable visual acuity, can be observed. And the other kid on the block, like I said, brolucimab, this came to India in December of 2020, and now nearly 10,000 injections of brolucimab have been used with very good results. And I'm very happy that Braille study, and this will be discussed in the second session. And there will be presentations by Prashant Baunkule on usage of brolucimab, as well as Dr. Manoj Khatri. A lot of people who have a lot of experiences on brolucimab will be discussing about brolucimab. And these are the various trials of ranibizumab and aflibercept, because of which, phase 3 trials, which they got approval. I just wanted to show one slide of my usage of brolucimab. I have experience of nearly 25 eyes. And this, you see, the upper one was free. This lady already had 6 injections of aflibercept. And you see this lady had not only SRFs and sub-RP fluid, his RP was stented. And you see what happened after one injection, 4 weeks. And there's a near normalization of the contour. This RPD, you see, haven't seen actually RPD flattening to such great extent with other agents. So this was a miracle which happened, and SRF also vanished away. Although this lady required 4 subsequent injections of Pagenex also. So the Pagenex, you see, whatever experience I have, has marked drying effect. If you see this green, table, you see these pre and post, there's a marked drying effect. And that is 100% there in a lot of these patients who are treated with brolucimab. And I think we will discuss about this. I'm not going to make a presentation on brolucimab at all. And I'm just going to speak something on anti-VEGFs at all. The beauty was that we in this small series did not encounter any intraocular inflammation as was reported, and which actually is the biggest fear for usage of, we did not see any vasculitis also. And same was the observation by the Eastern group from Disha and other people who didn't report in the Braille study at all. Other things which are happening, changing faces in anti-VEGF is this faricimab from Genentech is coming in a very big way. And it was, less than a year back that US FDA accepted this application for, because of the phase 1 and 2, this Boulevard study had excellent results on faricimab. And because it targets two distinct pathways, it targets Ang2 pathway as well as VEGF pathway. And a lot of studies have been done, phase 1 and 2. And relevant to ARMD are this Tanya and Lucerne study, which are their two identical studies, are there global phase 3 studies which have just finished about faricimab. And combined, you see, beauty of this was that 80% of faricimab treated patients were, we could Q12 or longer during the first year. Other thing I wanted to point out, not only about the wet ARMD, but geographic atrophy, the dry form of ARMD is also receiving great attention now, because you see C3 complement pathway is blamed for this, and this drug by the name of pegcetacoplan is targeting this C3 pathway. And again, this has been granted fast track approval by US FDA for the treatment of geographic atrophy. So even dry ARMD is catching some attention. And these are the two trials, Derby and Oak studies, which evaluated this pegcetacoplan pathway. And other thing which has happened about this anti-VEGF is that October last year, that is 3 months back, that Susvimo is the trade name for this port delivery system of ranibizumab. You see, till such time we are talking about ranibizumab being delivered every month or maybe treat and extend kind of regimen. But with Susvimo, you can have only 2 treatments in a year. But this is expensive at this moment, and the cost of the initial treatment is nearly $9,000, and the refill costs around $8,000. So this is the first procedure is done in the OR, and the second refill can be done in the outpatient department. So this offers a big hope that you see one of the unmet needs was frequent visits to the hospital, frequent OCTs, and frequent spending on doctors' consultation and evaluation for ARMD. With Susvimo, what has happened is only 2 visits in a year. And this was based on this Archway trials, phase 3 trials of port delivery system, by which this approval was granted in October 2021. So, as I said, anti-VEGFs have revolutionized this management of ARMD and so many other disorders of retina, which are listed here. And although effective, but compliance is an issue, not only here, but everywhere. You see, the biggest study on compliance was on real-world study was Luminous study, which said not only 40 to 50% of the patients, get injections which are 50% of the real of the trials. So now the role of biosimilars also are coming up in a big way, and it's a big change especially for us, because I believe, apart from the developments of what I told about PDS, about faricimab, about brolucimab, and so many other things, because of affordability, I think the whole world is shifting towards biosimilar, not only in India, but abroad also, because it benefits the patient. Patient becomes more compliant, and therefore we are able to reduce the blindness ultimately. You see, there's a big war of biosimilars going on, and everybody ultimately will reduce the price, and ultimately who's going to benefit is the patient. You see this chart which I had drawn a couple of months back. You see every company, right from Cipla, Novartis, Inter, Reliance, and Sun Pharma, so many companies are coming up with biosimilars. So just to summarize, the changing dynamics which Satyaj told me to speak about, I did not want to talk about brolucimab and other things. What's happening is the upper three, that is brolucimab, PDS, and biosimilars, are all already there in the horizon. And all of us, PDS has yet to make its way into India, but in the US, a lot of our friends have shifted to PDS. And time is not far when faricimab and this complement inhibitors will find a way into the armamentarium of retinologists. So thank you very much. This is what I had to speak about as an introduction to this great topic.
Thank you, sir. That was very informative. Anybody, any questions?
On behalf of the scientific committee, I would like to thank Dr. Lalit Verma sir, and I would like Dr. Pranav Ranjan sir and Dr. Vibhuti to also twist two words at this point of time.
Thank you, Dr. Satyajit, and I extend warm welcome to all our guest speakers, Dr. Lalit Verma sir, Dr. Manisha Agarwal, Dr. Manoj Khatri, Dr. Saurav Sinha, Dr. D.D. Chakravarti, Dr. Rajiv Raman, Dr. Kshitij Kumar, and Dr. Prashant Bhavankule. And apart from them, all the speakers, the moderators, the chairpersons, and above all, the audience. A very warm welcome to all of you, and we hope that this evening is going to be very, very useful. Over to you, Satyajit.
I'd like to request our secretary, Dr. Vibhuti Sinha, to say two words.
Just want to say welcome Lalit Verma sir and all the dignitaries and the guest speakers. Usually in a presentation, we catch 1 or 2 points from 1 or 2 slides. In Lalit Verma sir presentation, we usually catch many slides and many points. So each slides were very informative, and nearly would like to have those slides for my postgraduates. There were a few quiz questions also for Prashant there. So I'm sure he is also writing that. Thank you, sir, for sharing your vast knowledge and experience with us. Thank you, sir.
It was an honor for me. Thank you.
Thank you so much.
Can I share one experience, Dr. Lalit sir? I'm Dr.
Yes,
Subhash.
Yes, Subhash.
Sir,
आपको कोई जानता नहीं है, sir.
Sir, we have used nearly 45-50 injections of Tegenex. In one patient, we had frank endophthalmitis, and that is not still responding. Actually, we are trying to, now the infection has subsided, but there are a lot of vitreous debris, and patient is not very much keen of undergoing vitrectomy and all those. So that is one of the experience which I wanted to share in one of my patients had.
You know, that's an important thing which you have told, because honestly speaking, 1 out of 45 in case that is a sporadic incident, whether to blame it directly on the drug. You see, we have to distinguish whether drug has caused it or this
or
inflammation
the procedure itself.
or the procedure itself.
So
that I think that's $1 million question. But fortunately for us, we have not faced, and I read this Braille study and so many other studies, experience of Prashant, Manoj, haven't seen so much of inflammation at all. You see, therefore, when I started using, I used to photograph all my patients, first day, 5th day, every day, just to see, just to objectively document also and see with indirect and slit lamp. Because we were also afraid, because 4% incidence of IOI was, was too much, and even vasculitis. But believe me, there is something with the Indian eyes that we haven't seen so much, and so has been the experience. So I'm in the process of, compiling all this nationwide data and put it across the international audience also, that why. One thing which, appeals to me is that we, at least I do not use this brodocimab on a monthly dosage. I use it primarily as a PRN kind of regimen. Whereas Lucentis and aflibercept, we definitely use it, monthly injections, but haven't had the guts of using, brodocimab on a monthly basis, except 2 of my patients who have become addicted to Pagenex, and one 72-year-old gentleman has received now 9 injections, and one, this lady which I had shown in my presentation, she has received 6 injections. So these people actually have become addicted in the sense they come begging for it and they come and get it done, Pagenex. So much is the response of RP attachment and SRF. And every time this lady undergoes this injection, her vision comes back to 6/9, 6/6 parts, and her metamorphosis disappears. So that is the
one question. Does the repeated injection increases the risk of inflammation, or the first injection itself is a risk?
Yeah, you are right, because the more the number of injections, more the possibility of inflammation, definitely. But haven't seen actually till date.
Do you think is it because of the loading, first 3 loading doses which we give, like what probably we in India are giving, but probably the Western or the Eastern people are giving? That
absolutely, Abhishek, that is the reason you are right. That Merlin study, which Novartis was actually sponsoring, that Merlin study, they had to stop in between because the Merlin protocol was that you have to give every 4 weeks, and they started encountering intraocular inflammation. And that is the reason, Novartis, who was the main sponsor, stopped it, adhering to the ethics protocol. That if the patients were encountering this inflammation, they stopped it.
Thank you, sir. We'll move on to the.
Actually, a lot of inflammation we do see, sir, post-Pegenex. In fact, I have seen 2 patients. One was injected by me and other was another center. And he came just for an opinion. And that was significant vitritis. It was not endophthalmitis, definitely. It was responding to this just topical steroid and systemic steroid. But massive vitreous debris I could notice in both these patients. So we cannot say that it is completely like Indian eyes are completely free.
Doctor.
I agree. SPT, I 100% agree with this. You see, all of us have to collect this data. I said out of my this thing, we did not. The Braille study did not. Out of 126 eye injections Braille study gave, they did not see even one inflammation. What I'm trying to say is the hawa which was created and the fear in the minds of people. You see, I also don't use Pegenex the first line of management at all. What I reserve it, I talk to patient that if the patient is not responding to repeated injection of ranibizumab or aflibercept, then I definitely give them an option that here is a new drug, and we get a separate consent form. There's separate consent form of Pegenex. We do inform them that there's an option because people nowadays come with Google knowledge. And if you don't tell them, they feel cheated also. So my job is to inform them there's another kid on the block, you can try. And all these patients have already had failures with aflibercept and ranibizumab.
Sir, can I add one point? Actually, one of the hypotheses that was have been implicated is why the Indian eyes are having less prone to the inflammation in comparison to the Western world is that we don't have that many eyes which have Eylea injected. So what they have found is that injections who have eyes which have already injected with Eylea, their antibodies might be cross-reacting with Pegenex. So that is one of the hypotheses that Indian eyes don't have that much. And also Indian eyes don't tend to follow that very strict protocol of 4 weeks. So these are 2 hypotheses that why Indian eyes are less reacting to Pegenex.
Abhishek, I agree. I am aware of this hypothesis, but as SPT said, Indian eyes are no different than Western eyes, honestly speaking. But you see, we should be cautious. We should be aware that this can cause inflammation, and but nevertheless, but it does wonders in select group of eyes. I am sure that Manoj Khatri and Prashant will be sharing their slides also.
Thank you, sir. Thank you so much. Dr. Meha, can we move on to the next speaker, please?
Okay. So now I'd like to call upon Dr. Naila to speak on the physiology of macular degeneration, on the most common retinal pathologies ailing our elderly population. Dr. Naila did an MBBS from AIIMS Patna, and presently she's doing a post-graduation from AIIMS Patna too. And the discussant for this case is Dr. Abhishek Kedia. He did his vitreoretinal fellowship from Arvind Eye Hospital and the prestigious Sydney Eye Hospital, Australia, and presently is a phaco and vitreoretinal surgeon at ARA, practicing at ARA in Bihar. So Dr. Naila, over to you.
Good evening to all. Today I'll be presenting about the physiology of ARMD. We'll go through an overview of introduction, then microstructural changes in the relevant anatomical structures, pathophysiology, and conclusion. So to introduce age-related macular degeneration is an acquired disease of the macula characterized by progressive visual impairment because of late onset neurodegeneration of the photoreceptor RPE complex. It's a major cause of central visual loss in a developed nation, affecting around 10% of the people older than 65 and 25% over 75 years. And by the end of 2040, it has been expected that the global prevalence would be around 300 million. And there has been decrease in the incidence of legally visual impairment because of it due to introduction of treatment targeting VEGF. So coming on to the anatomical changes or the microstructural changes, the Bruch membrane is one of the structures which is involved. It is a 5-layered extracellular matrix which consists of RP basal lamina in a collagenous layer, elastic layer and outer collagenous layer, and choriocapillaries basal lamina. The collagenous layer and the elastic layer are the one which provide the structural layer to the Bruch membrane, and the elastin layer is one of which gives anti-angiogenic barrier function also. At the macula, it is sparse, and due to this discontinuity, we can say that why CNV are more common at the macula. The aging in the Bruch membrane is seen as lipid-rich material accumulation, which is cholesterol-rich also, as containing apolipoprotein B and E, which is assembled. And we can see that the Bruch membrane also thickens along with as the patient ages, and by around 2 to 3 times at macula, that is more at the macula and lesser at the equatorial and podociliary region. So what does Bruch membrane do? That it acts as a selective conduit for nutrient transport to the retina from choriocapillaries and metabolic by-waste products transported from the retina to the circulation. So this is impacted to the Bruch membrane via the hydraulic conductivity of it, which is reduced as the patient ages due to high lipid content of the Bruch membrane. So this leads to hampering of the function of Bruch membrane and leading to accumulation of fluid in the sub-RPE space. Now coming to the next structure, that is RP, retinal pigment epithelium. It has various specialized function already discussed in the previous presentation. And one of the most important which gets affected here is that the renewal of the phototransduction machinery. That is the RPE digests or ingest the outer segment of the photoreceptor. And this leads to like a propagative mechanism of recirculation. And it also acts as the outer blood retinal barrier. So macula, where there is the highest concentration of photoreceptor, RP is bound to be most metabolically active here and most likely to suffer the consequences of enzymatic failure over time with the accumulation of metabolic debris and lipofuscin. These lipofuscin and residual bodies, they accumulate and these fluoresces and on the fundus autofluorescence that we could see, and these can be used as an index of 8 changes in the RPA. Now coming to the gross core pathophysiology. Basically, there's a loss of vision in AMD due to the result of degeneration of photoreceptor, which occur when the retinal pigment epithelial cell, which are associated with it, deteriorate and die. The primary locus is 3-layer, that is RP, Bruch membrane, and underlying choriocapillary. And these are centrally located lesions, hence leading to gross loss of vision. Grossly, we can classify it as early and late stage. In early stages, we can see drusen and abnormalities in the RP. In late stages, we can either see geographical atrophy or neovascularization. So the RP cells are in a state of a continuous continuum of repeated synthesis of new molecules to replace the apoptotized or digested molecules. But this system is not proof-free. That is, this system can get affected with aging. So what happens that now the RP are not able to remove as much as cells, as much as it is synthesizing. So these get accumulated. These accumulation of the abnormal molecule is because of the imperfection in the cell's digestive mechanism. And these residue then gets deposited and leading to formation of drusen in the form of lamellar deposition and within the Bruch membrane. And eventually it leads to formation of either choroidal neovascularization or death of RP, further leading to death and degradation of the photoreceptor. So since ARMD is a macular disorder and it could be characterized as one of the following 4 features, either drusen, RP abnormalities, geographical atrophy, or neovascularization. So coming on to drusen, these are multiple small yellowish white lesions located within the Bruch membrane. Since drusen is something which we can see in all the elderly patients, so not all drusens are one which leads to ARMD. Large soft drusen which are within 2 diameter of fovea are most commonly considered to be the feature of ARMD. And these are the one which large means that is it is more than 63 micron, and soft means the marking, the border are poorly demarcated. So soft drusens are synonymous with the basal linear deposition also, which leads to thickening of the base Bruch membrane. So we have 2 types of deposition, basal laminar and basal linear. So the basal linear deposition is the one which accumulates between the first and second layer of the Bruch membrane, that is RP basal layer and the inner collagenous layer. It starts as a lipid wall, then it exaggerates and leads to basal mound, and following which drusen occurs. In basal lamellar deposition, there is deposition of the apolipoproteins and the lipid within the between the plasma membrane of the RP and the Bruch membrane. So these 2 types of deposition are the one which are basically 2 physical forms of the same AMD specific lesion, that is drusen. So blind or the basal linear drusen consists of the granular and vesicular lipid-rich material and may contain widely spaced collagen, whereas basal laminar deposition, they consist mainly of widely spaced collagen. So how we identify or differentiate the size according to the size of drusen? Small is less than 64, medium is 64 to 124, larger is 125 to 250, and very large is equal to or more than 250 microns. The soft drusens are associated with an increased risk of development of RP abnormalities, geographical atrophy, and choroidal neovascularization. Coming to the next abnormality that could be seen, that is RP abnormalities. These are focal hyperpigmentation of the RP, which are seen as area of increased gray or black pigmentation. These could be punctate, linear, or reticular, and appear as block fluorescence on fundus fluorescence angiography. The correlation which we could make with it is that these are basically to the pigment migration of the RP cell to the photoreceptor nuclei. The next abnormality that could be seen is a geographical atrophy, also known as areolar atrophy. These are one to several areas larger in size, up to 175 or more than that micron in size. These occur at where there is discrete absence or attenuation of RP, such that underlying large caliber choroidal vessels could be seen over it. And over the geographical atrophy region, there is a thinning of neurosensory retina, and there is loss of photoreceptor also. Hence, this is the part when we can say that the patient has gone to a late ARMD phase. So how does GA geographical atrophy evolve? It evolves either at the area of a large soft confluent drusen. When it regresses, it leads to GA, or spontaneous flattening or loose of the serous PED, or resorption of drusenite PED. All of this could evolve to GA. So soft drusen, when it changes into fibrous tissue dystrophic calcification, leading to hyalinization of the Bruch membrane. These all could also be a clinical pathological correlation between how the process continues. And RP, finally, what happens is that the RP basically disappears and lead to formation of geographical atrophy. And the last one, that is the most feared form of ARMD, that is exudative maculopathy or the wet ARMD, where new vascularization forms. Here, the diffuse thickening of the inner aspect of Bruch membrane, basically which is associated with large soft drusen. These predispose to the formation of cracks in the Bruch membrane. So this is one of the hypotheses that through the crack, the new vessels could egress and lead to the formation of new vascularization. But since these cracks are also seen at other places of retina where there has been no new vascularization, so other factors have also been provoked at this point, like a chronic granulomatous inflammation in response to degenerated Bruch membrane due to the accumulation of all these lipid proteins. And increased scleral rigidity has also been found to be one of the factors leading to new vascularization. And destruction of the RP, which itself releases lots of factors which are angiogenic, hence also leading to formation of choroidal neovascularization. To conclude, the preceding points indicate that the age-related macular degeneration is an exaggerated or advanced stage of the normal process of senescence of RP, and RP Bruch membrane complex acts as an integrated unit. And once one segment is affected, the other also gets involved. Due to the destruction or deterioration of the RP, there is further later degradation of photoreceptor. And these are what we clinically see as formation of drusen, further predisposing, coalition, and later predisposing to the formation of geographical atrophy. And at the last stage or the late stage, we get the wet ARMD or choroidal neovascularization. Thank you.
Thank you, Dr. Naila. You have very comprehensively outlined the various aspects of ARMD pathogenesis. Over to Dr. Abhishek.
Very well presented, Naila. I think she has discussed most of the points. I'd just like to highlight a few important points. Am I audible and visible?
Yes, sir.
Okay. These are the various, since ARMD is a complex disease and it has multifactorial origin, we still to date do not know the exact etiology and the pathogenesis. So these are the various treatment options which we have. So why I have come to this slide is because we need to study the pathogenesis according to all these points which somehow or the other leads to the macular degeneration. So basically we have treatment for wet AMD, but for dry AMD, like the early or the intermediate AMD, the treatment is not available. So it is important to understand the pathological mechanisms which lead to all the diseases, as Naila has discussed. I would just like to highlight a few changes which occur in this disease. It's mainly, one thing is important is the role of disturbance in the oxidative equilibrium between the amount of reactive oxygen species and the antioxidant production, or the capacity at which the RPE cells can release it. Another important thing is the photoreceptor cell loss, which happens mainly in the area of parafoveal region, and the the changes start in the rods, and gradually the cones are involved, and the advanced stages the cones are the mainly involved in the advanced disease. Though the choriocapillaries become thinned and sclerosed out, as we all know, and there is reduction. The retinal toxins get accumulated in the Brooks membrane, and with age, we know the Brooks membrane gets thickened. The genetics have also got a role in this.
Abhishek, we are not sure if you're moving your slides. We are stuck at the first.
No, I'm not moving my slide. I'm just trying to discuss all the points.
Sorry, go ahead.
So all the loci from chromosome 1 to 12, most of them are involved. So the gene therapy is also being studied these days, and our understanding regarding the molecular pathogenesis of the VEGF is well known these days. So we mainly concentrate on anti-VEGF molecules, but we still need to understand the etiopathogenesis and the pathology involved in the dry form, mainly the intermediate and the late form, and we need to look for the treatment of all these causes. Thank you.
Thank you, Dr. Abhishek. Now we'll move on to the last topic of this session. I would like Dr. Pooja Sinha to present her case. And Dr. Pooja Sinha did a VR fellowship from Shankar Nethralaya, Chennai. After that, she's been trained in reputed institutes like Stanford and the Oxford and Hull Eye Infirmary. At present, she's the head of vitreoretinal services at AVI Institute, Patna. And to discuss this case, I would like to introduce, though she does not need much introduction, Dr. Manisha Agarwal. She is the current head of retinal services at Shroff Charitable Eye Hospital, Daryaganj. And also, she is currently holding the prestigious position of the Secretary of Vitreoretinal Society of India. She is a very reputed name in the field of vitreoretina and has a large number of publications and research papers to her name. Welcome, Manisha, ma'am. And
thank you, Meha.
And also, I've had the privilege to train under her. So I work with Dr. Manisha. Okay, Dr. Pooja, ma'am, you can present your case.
A very good evening to everyone. Am I audible, please?
Yes, ma'am, you're audible.
I'm very thankful to Bihar Ophthalmic Society for giving me this opportunity. Today evening, I'll be speaking on an interesting topic, when best is not best enough. So this was a 55-year-old male patient who came with diminution of vision in the right eye. One second. He reported in October 2020 with diminution of vision in the right eye for the past 3 months with central distortion. The vision at the time of presentation was 6/24 partial. The clinical picture was a very small subretinal whitish lesion in the macular area. The corresponding OCT showed an RPED with clumpy deposits between the RPE and the Brooks membrane. This was the clinical picture of the left eye, where there was stippling in the macula. Vision was 6/60, and there was distortion of the layers in the FAZ. At this stage, I diagnosed the patient as Best disease, and I didn't offer any active retinal intervention at this point because I didn't see any progression of the disease, and I didn't see any clinical features of CN vein. The patient again reported in March 2021 with further distortion of vision. At this time, again, in the clinical picture, I didn't see any subretinal neovascularization. OCT at this point showed, there was a discontinuity of the RPE, and the lesion size had increased a little. And that is when the patient was unhappy, and he said that, "Madam, I'm facing more distortion of vision." And that is why I decided to give him injection eccentrics. After the second injection of eccentrics, the vision improved to 6/18. The lesion size had decreased. And this was after the third injection when the vision was still 6/18, but the patient was relatively happy because he was feeling symptomatically better. This was the clinical picture after the third injection, where there was a slight amount of RP stippling and no progression of the disease. The OCTA at the end of third injection did not show any, neovascularization. There was no CNV at this point. There was a mild amount of stippling and some discontinuity of the outer retinal layers. Otherwise, it was not very remarkable. This was case 2. A young girl who presented to me with a yellow subretinal deposit just adjacent to the fovea. And she said that there was slight distortion of vision for the past 3 months. This was the picture of the right eye. And then you see the picture of the left eye here, where there was a large scar just adjacent to the fovea. And the patient had received 1 injection of injection eccentrics earlier since the last 6 months before she presented to me. And she came to me primarily because in the right eye also she had started having a little bit of distortion. This was the OCT of the right eye, where you could see the RP detachment along with this amorphous deposit between the RP and the Brooks membrane. Again, I did not see any CNV changes in this eye. And there was no subretinal hemorrhage as well. In the OCT picture of the left eye, I could see a significant amount of fluid in the subretinal space adjacent to the scarred area. This was the OCT-A of the right eye on presentation. There was no CNV that I could make out, no new vascularization that I could make out in this OCT-A picture. So my queries for discussion in this case are, in the presence of disciform scarring and subretinal fluid, should a repeat anti-VEGF injection be given in the left eye? The right eye does not show any classic features of CNVM, either clinically or on OCT or OCT-A. So does this warrant an anti-VEGF injection based on the patient's symptoms, since it's juxtafoveal and the patient is complaining of distortion of vision and location being juxtafoveal and other eye findings? And is EOG mandatory in diagnosing all cases of Best disease or clinical features are sufficient? So to describe Best disease, excuse me, one second. To describe Best disease for the, one second. So for the benefit of the postgraduates, I would just like to have a few slides on Best disease. Best disease was first described by Adams and later described by Frederick Best, who had a detailed pedigree of the disease. It is a hereditary retinal dystrophy involving the RPE and leads to a characteristic bilateral yellow egg yolk appearance of the macula. The disease presents in early childhood and can extend into early adulthood as well. Etiology is it is an autosomal dominant pattern with diminished penetrance and highly variable expression. The causative gene is located on chromosome 11, and that is the best one gene, as we all know. The basic pathophysiology is believed to be a primary disturbance of the RP, and it is theorized that there is an abnormal chloride channel in the RP, which leads to a buildup of lipofuscin, a retinal pigment between the outer retina and the RPE. This buildup leads to appearance of the typical subretinal vitiliform lesion, often described as an egg yolk lesion, and eventually leads to a slow or mild moderate visual deterioration, either if a CNV is developed or it just leads to rapid scarring, which causes visual loss. These are the 5 signs of Best disease: the pre-vitiliform stage, which is evident as a small round yellowish dot at the center of the foveola; the vitiliform stage, which can lead to appearance of the cyst with fluid levels or sometimes clear space in the center with material situated all around. CNV is obviously a complication. Pseudohyperion stage, which may occur when the part of the lesion regresses, often at puberty. The vitelli-eruptive stage, when the lesion breaks up and and the atrophic stage, which can be represented by the area of RP atrophy or sometimes disciform scar if complicated by CNV. Diagnostic tests, as we all know, it can mostly be diagnosed clinically, as I did in my cases, but EOG and ERG are also very important diagnostic tools. EOG, which is usually abnormal, and there's an ardent light a dark ratio of 1.5 or less. ERG in these cases is completely normal. OCT, as I showed in my cases, is a very important diagnostic tool, which is used to localize the vitiliform lesion to the subretinal space, demonstrate the thickening of the cone outer segments, and can be used to evaluate for fluid associated with CNV, which can lead to devastating visual loss. Fluorescent angiography is very important. It shows hypofluorescence of the typical vitiliform lesion, because as I told you that there is lipofuscin in these lesions and that causes hypofluorescence.
It's
But when
8 o'clock.
the disease progresses, there is the mixed pattern of hyper and hypofluorescence. And when the lipofuscin degenerates and disintegrates, then there is hypofluorescence because of the background choroidal fluorescence. Fundus autofluorescence, as I have already explained, in the early vitiliform stages, there is hyper autofluorescence, which becomes hypoautofluorescence as the disease progresses. There is no medical or surgical management for Best disease. CNV, as I've already told you, can be a potentially devastating complication. Application of anti-VEGF agents for CNV in the setting of Best disease has shown potential for improving outcomes, and photodynamic therapy has been attempted as well. It is important to differentiate Best disease from age-related macular degeneration, dominant drusen's, CSR, toxoplasmic retinochoroiditis, and solar retinopathy. And we have to keep all these things in mind when we are making a diagnosis. Thank you so much for your patient hearing.
Thank you so much, ma'am. They were really interesting cases. Over to Dr. Manisha.
Thank you, Meha. And I thank BOSS at the outset for this kind invite. And thank you, Dr. Pooja, for showing such interesting cases, which very often we see in our clinics. Now, just for the benefit of everyone, and especially the postgraduates, I think the most common differential diagnosis for this case, but in particular, when we see a case of Best, would be a central serous chorioretinopathy with a subretinal fibrin deposit. And that is something which we really need to keep in mind. And there would be certain things which are going to help us in differentiating between the two. Firstly, there would be a probable history of either a steroid intake or the type A personality in a CSCR patient. You can see a pocket of a serous detachment along with serous PEDs. And of course, when you do a fundus fluorescein angiography, that is, of course, going to be very much confirmatory that either you are dealing with CSCR or you are dealing with Best disease. Now, the problem happens when we are seeing, like Dr. Pooja showed, a spectrum of two cases. One was above 50 years of age and the other patient was much younger. Now, when we are dealing with a patient of a vitiliform dystrophy in the older age group, that is a 50 plus, I think the most common differential diagnosis, of course, that comes to our mind would be an age-related macular degeneration. And again, over here, you have to be very sure that either you are dealing with a choroidal neovascular membrane associated in a 50 plus patient, which can be confirmed either by doing an OCTA or by doing a fundus fluorescein angiography. And if you find that there is an element of a CNVM, then of course that person is going to be needing a treatment with anti-VEGFs. Now, both the etiologies, whether it is an AMD or it is a Best disease, they can get complicated with a CNVM. So in these patients, we have to be very careful to identify a CNVM. So when a patient is presenting with a drop of vision, I think the first thing that we need to do is to rule out the presence of an underlying CNVM, which would need an urgent treatment. Otherwise, there would be an irreversible loss of vision. So that is something I would suggest that everybody needs to look for. But if you have confirmed that there is no underlying CNVM and you find that there is only an element of a vitiliform deposit, whether you're dealing with an adult vitiliform or you are dealing with a Best disease in the younger age group, they apparently don't warrant any kind of treatment. And you just have to observe these patients. The good part of the Best disease apparently is that usually one eye continues to maintain a good vision and the other eye probably can land up with what Dr. Pooja has shown in her second patient, that the left eye developed a gross RPE atrophy with quite a significant loss of vision. So this basically happens in Best disease because there's a deposit of lipofuscin both in RPE cells and in the photoreceptors. And this can lead to the degeneration of the RPE, the photoreceptors. There can be a loss of the RPE continuation. And all this can result in a gross RPE atrophy, resulting in a gross loss of vision. So what is suggested for these patients is, one would be that you must call in all the family members, because we know it has a hereditary predisposition. It can be autosomal dominant or recessive. So one suggestion would be that please call all the siblings and check if they're having any similar kind of the disease pattern. And the second would be to keep a very close watch on the right eye of the second patient, especially because that is the only seeing eye of that patient. I really don't think that the patient is going to benefit much on treating the eye, which has already gone into an atrophic stage. So the right eye, of course, would need a very close monitoring with probably an Amsler grid, a frequent OCT checkup, and all those things. As far as your question of EOG is concerned, because we have so many differential diagnoses, I think we need to surely confirm if we are dealing with the best, because the diagnosis is confirmed on doing an ERG, which will come out to be normal, and an EOG, which is going to come out to be as abnormal. So that is something which will confirm your diagnosis that you're probably not dealing with any other etiology. So this is from my side. I think Dr. Saurabh Sinha wants to make a comment.
Three comments. Pooja, can we go back to your slides, please?
Yes, yes, that's what I want to. I'll just go back to my slides. Yes.
I've been trying to figure out the OSTA business a little bit of late. Multiple presentations, reading up journals, articles, actually downloaded some books. And I'd like Manisha to comment on this. If we can have that, please.
Yeah, I'll just open it.
The OCTA picture. Yeah, go back. Yeah. So Manisha, the one that she's highlighted here, why would that not qualify as a CNV?
So if you are going to be seeing this, Dr. Sinha, you do have flow signals actually, which is coming over here, which actually will be suggestive that you're probably dealing with a CNVM. But you see, there's a lot of disturbance. You have the flow signals throughout over here. So I would personally go ahead and I will see a video of this OCTA before I say whether I'm dealing with a CNVM.
That is my point. I think what Manisha is making an important point is just looking at one this slide over here should not be the reason to decide it's a CNV or not. I think it's a very important point. But per se, this one looks like you have a CNV. Look at the simple OCT down on the left side also. You have a fusiform thickening there. Good old OCT or tortoise fusiform thickening could be a CNV. Do a fluorescein angiography. This is a good case where I would insist on a fluorescein angiography, not rely on OCT angiography. However good it is, do a fluorescein angiography this patient. Best disease, you want to inject, don't want to inject. I think a fluorescein angiography will give you some more important data over here. And even the previous case, I thought there was a CNV there, but again, that the patient responded, so must be the first case that you had. Yeah. No. Next slide. Was the OCT angiography done initially?
The OCT I had done initially, but I didn't see any CNV complex in this patient as well. And there was no clinical subretinal
We don't discuss it to any of us. And we had a large meeting here with all our Calcutta colleagues over here. And we figured out how less we know about OCT angiography and how we have to actually go sit to the machine. Exactly what Manisha said. Go to the machine yourself, see all the slices yourself, see all the levels yourself. It's very important. And if you still have a doubt, go to angiography. These are my only 2 points I want to make. That's all. Thank you.
I think you've made a very valid point, Dr. Saurabh, because I think FFA will give away a lot of information in this patient, especially. Since the lesion is juxtafoveal in both eyes, Dr. Manisha, the vision was not that poor in the left eye. Vision was still about 6/18, but she is very much bothered by distortion, and she has received one injection of eccentrics in the left eye. But she didn't go ahead with the rest of the injections.
So I think, Pooja, what we have to understand is that if there is no underlying neovascular complex, I don't think that the anti-VEGFs per se are going to be having any benefit. So as Dr. Sinha has made a point that FFA surely would be something which will confirm the presence of CNVM, because as we all know in Octa, we get a lot of artifacts and sometimes you're not really able to confirm whether a CNVM is there or not. And the second thing we have to keep in mind is if we are unnecessarily giving the anti-VEGF injection, they themselves can be a factor causing RP atrophy. So I don't think that unless warranted, we should be really injecting it with the hope that it is going to be showing some improvement.
Okay, thank you so much.
Dr. Rajiv wants to say something.
Dr. Rajiv?
No, beautiful case and very nicely presented, Pooja, reminded of all the old fellowship days. Can you just open your slides once? See, as Saurabh rightly said, and actually both of them, even Manisha told, EOG is good, but what we are looking at is RP function. Even autofluorescence would give a very good information, especially when you are looking at vitiliform lesions. Second case, autofluorescence, if you get a speckled autofluorescence in the macular area, it's usually an adult onset vitiliform. If you see a speckled one with a ring of hyperautofluorescence, that is typical of a Best disease. And when you see no autofluorescence at all, it is adult onset pseudo-vitiliform dystrophy, which can be. So the moment you see a vitiliform type of lesions, definitely autofluorescence becomes an important stay. The second case, if you see this, what you describe this as a SRF, or it's basically dipping of the choroid, which is happening. Sometimes they describe as choroidal excavation, though it is not a tumor thing, but it is more towards, that is more suggestive of atrophy. You can get this in a vitreoeruptive phase. Second case, yes, looks like there are features of Best. Even the first one, can you show the other eye? Other eye, yeah. There are features of Best probably, but again, as rightly said, that doesn't seem to
recording in progress.
The first case.
The first case is really interesting.
Can you just show the
Can
first
you just
case?
show the first case? Fine.
See, you don't see
See,
any
you don't see any vitiliform lesion.
I don't know why we are.
I don't know why we are
going.
going.
I don't see any.
I don't see any
vitiliform
very clearly
vitiliform
lesion.
But you can see a back scattering, which is more suggestive of a bit of scarring at the beneath this pigment epithelial detachment. Other eye, other eye.
Other eye was like this.
Yeah, and now after anti-VEGF, what you are in this, if you see, there is a shadowing. Was there any pigment there?
No, there was no pigment, and actually I didn't actively treat this eye.
Yeah, go to the treatment. After treatment, you again see a hyper-reflective thing, which is causing a dark shadowing. If you can see, there is a shadowing down, which either a blood can cause or a pigment can cause. So this hyper-reflective thing with a total shadow, which is seen down, was there anything there?
Dr. Rajiv, what could this be? I thought this was just disruption, disruption
But
of the
this is
RP.
causing a shadowing. If you look at down, the tubular shadow is
There was
seen.
no blood.
Pigment.
There was no blood.
No blood, no pigment.
No
Because
blood or no pigment.
Shown first time, I would not call this as a Best or any vitiliform. I'll more call towards a PFT. My diagnosis will more go towards perifoveal, this whitening. And PFT, if you are considering doing an angiogram, in this case would be important information. Or if nowadays I am not doing angiograms, I am doing double wavelength autofluorescence to look at identifying it, whether it is basically macular pigment, distribution of macular pigment. I usually diagnose MACTEL with that. So I would more consider it towards a MACTEL, this patient.
Does the morphology of this picture here, this kind of dome-like elevation of the RP,
inner cyst with atrophy.
Yes.
Yeah, inner cyst with atrophy, outer retinal cyst with atrophy. No inner cysts are there. Other eye causing a atrophic lesion. One of the differential would be there. So not a bad idea to get an angiogram in this. This is again a 50-year-old gentleman.
And correct? I think an autofluorescence, this was the elderly gentleman.
Yeah.
So I would also, Rajiv, I will also agree that the first case, I don't think will fit into a Best.
Correct.
The second one is, but I would also keep an adult Whitley form for the first case as one of the differentials.
Absolutely, absolutely true. Autofluorescence, as I told you, autofluorescence FFA would give a good idea.
Yes, yes. I missed out on the autofluorescence, though my machine has all the features, but I didn't.
Yeah, you should have done autofluorescence. It would have just cleansed the diagram.
Very useful tip. Thank you so much.
Okay, we'll move on to the next talk now. Maya, can you just give the closing remarks?
Thank you, Dr. Manisha.
Dr. Meha, are you there?
Yes. Okay. Thank you. So this was a very informative session and wonderful talk by Dr. Lalit and all the other speakers. So now we'd like to move on to the next session. And the next session, I would like to call upon Dr. Vishal. Dr. Vishal Kishore to moderate the second session.
Thank you, Maya. Now, in the next session, the first talk is by Dr. Manoj Khatri. Now, Dr. Manoj Khatri is basically from Chennai, and he's the founder and managing director of IDOX Eye Hospital. He's a senior ophthalmologist and chief of Rajan Retina Foundation at Rajan Eye Care Hospital, Chennai, and a senior consultant at Apollo Hospital. He has done his VR fellowship from Prestigious Institute, LV Prasad Eye Hospital, and he has several papers reviewed in peer-reviewed journals, both nationally and internationally. And he is the principal investigator in many of the drug trials. His keen area of interest lies in ROP, diabetic retinopathy, and challenging vitreoretinal surgeries with cataract and phacoemulsification surgery. So now on to Dr. Manoj Khatri on his talk on switch over anti-VEGF therapy in DME and neovascular AMD. When and why? On to you, sir.
Dr. Vishal, 1 minute. Can you please invite the chairperson and the expert?
Okay, fine. Sorry. I'd like to invite the chairperson, Dr. Vibhuti, sir, Dr. Nagendra Prasad, sir, and Dr. Sudhir, sir, and Dr. Nilesh Mohan. And the expert panelists, Dr. Sevendra Sahai, sir, Dr. Rajesh Agarwal, Dr. Shishir, and Dr. Shivani. Okay, so we can start the talk.
Thanks, Vishal.
Thank you, Vishal, for the kind introduction, and many thanks to BR Ophthalmological Society for the kind invitation in getting all of us here on this virtual platform on the topic of update on retina. So common things which we always encounter in medical retina practice is, does our anti-VEGF therapy is going to work in the way which you want? If at all you want to consider other injection, when is the injection, when is the time, what injection you will like to switch over, and why you want to switch over at all. So these are the common thoughts which all of us face in day in and day out in practice. No financial interest in my talk. So when we look at the current scenario of neovascular age-related macular degeneration treatment, often the question asked is brolucizumab, when it is available, it is a panacea of treatment with a single anti-VEGF injection. The answer is no. Why we need to understand this is the last 7 to 8 years, what we have also understood is neovascular age-related macular degeneration is a chronic complex disease, which have been beautifully highlighted by the previous speakers on both anatomical and the physiological pathway. So there are multiple pathogenic mechanisms, and there are a lot of data from various drug trials which is available and which we are realizing and making it useful in our day-to-day practice. But there are certain things which we always need to ponder as non-responders, incomplete response, unresponsive, treatment resistance, recalcitrant, and the list goes on. So basically the same thing with a different terminology, and tachyphylaxis, as we already know, plays a very big part in the treatment of neovascular age-related macular degenerations. There are some proposed definitions for this as how you want to highlight is something called as a refractory, something as a recurrent, and something as a recurrent to anti-VEGF therapy altogether itself. And how do you assess the response to the therapy? So there are researchers who have given us some guidelines on good response versus partial response versus to no response. So again, coming to the point whether we are with these newer anti-VEGF molecules, is there any single agent that may be answer to all the resistance, recalcitrant, or recurrent cases? Probably no, I will say at this point of time, as more and more experience will be available in due course and with newer anti-VEGF molecules, maybe we'll be able to get a substantial answer for this. So now the point comes is, you have a patient, you want to manage this patient, and how are you going to manage these patients? So first and foremost is try to make a framework of your diagnosis. Sometimes it is always wise, it's been told by our teachers as well, as you revisit your diagnosis altogether. So sometimes there can be a misdiagnosis, There can be a lot of other factors like genetic factors, tolerance, tachyphylaxis, and all this will be playing the part which you have missed in initial management protocol itself. So always go to the drawing board, revisit on the possible cause of the problem, and then try to think about anti-VEGF switchover. Now, wherever we say switchover, the data which has been there in the literature, the switchover therapy has been bevacizumab, ranibizumab, and aflibercept, and which have seen with over a period of time that switching from one agent to the other agent and vice versa can give you a very satisfactory outcome, both reducing the complex of the neovascular disease as well as reducing the central subfoveal thickness and improving the best corrected visual acuity. So I'm not going to the details of these trials, but what we have seen in one of the meta-analysis is the heterogeneity always plays a very big significant part, though there were some shortcomings of the meta-analysis as well. But what people have highlighted it, whenever you have this kind of problem, go for a monthly dosing rather than PRN basis, and also keep a watch on tachyphylaxis, and switching to another drug with an alternative mode of action really helps. And your clinical judgment also plays a very vital part in deciding on the further treatment protocols. So as I said, the published data is till aflibercept. As of now, we are studying on the brolucizumab whether the switchover really helps. These are the couple of cases taken from the studies. And then the question comes is, does aflibercept switchover therapy from other anti-VEGFs always help? And what with the newer data has also been showed by Hawk and Harriet trial that the switchover really helps over a period of time, but we have to see whether these patients have recurrences. We have seen patients who have on brolucizumab, they have certain recurrences at a certain point of time. And we need to see over whether we can go from a higher anti-VEGF molecule to a lower anti-VEGF molecule in due course of time. So just in the interest of time, we'll skip all these things. But what we have to see is what is the morphology at hand. Then you decide whether we are getting a good response or a no response. And what is the visual acuity? So these are the two basic guideline areas where we can, in your clinic, with a simple judgment, we can go ahead and then decide whether you want a switchover therapy for neovascular AMD or not. And then comes the anatomical and functional outcome over a period of time for all these patients. So just to summarize here on one part of my talk, we are dealing with a chronic complex disease in form of a neovascular age-related macular degeneration, which has been driven by multiple pathogenic mechanisms. How to classify optimal response is still we are learning, and we are evolving on these definitions. In all the definition status, I think tachyphylaxis and recalcitrant, these are the two things which we have to keep it in mind, and always make sure that we need to keep it in back of our mind that switching from one agent to other generally helps in overcoming resistance to specific anti-VEGF agent, and this applies to all the different drugs, including bevacizumab and ranibizumab. Couple of cases, I will not going to go in details. This was one of the recalcitrant IPCV case which we treated with brolucizumab. It's not like that the patient was not getting response with the other anti-VEGF, but we wanted a faster resolution because it was a young patient. We got a favorable response in due course. Over a period of time, this patient also had a recurrence. The recurrence has been treated with the same thing and had good response. In couple of elderly people, we have seen the response is quite good. This was one of the cases where it's a recurrence of an occult choroidal neovascular membrane with so much of Schrem lying here. And we wanted to get a good response, so we shifted straight away to brolucizumab rather than going for the other anti-VEGF. And patient did quite fairly well. And over a period of time, this patient had a very good anatomical and functional outcome. These kind of cases, I'm sure have been seen by other people as well here on the panelists. So this kind of outer retinal changes, when you see, indicates the chronicity of choroidal neovascular membrane. And with one single injection after switchover to one higher anti-VEGF molecule, you can get a good response. So again, in the interest of time, I'm just going to skip over on all these cases because this will be discussed further in due course by the other speakers as well. But what I want to highlight is that the switchover therapy, whether it is a pigment epithelial detachment or a choroidal neovascular membrane secondary to occult disease or IPCV, or they have been, people have seen, and there are published data available that switchover therapy really works here. However, the case selection remains quite vital, and we need to pick and choose our case, and also time, the therapy as what we are going to see. This patient had a large pocket of subretinal fluid. We were quite doubtful whether this patient will ever respond to treatment. But what you see with the single injection, this patient has responded quite well to switchover therapy and did fairly okay over a period of time. So just to summarize the first part, we are dealing with a challenging disease here, which has multiple pathogenic pathways. Though there are some new promising agents, but we need to keep and case selection is vital. And when are you going to switch over? That also remains the key. Whether the patient you want to start on the primary therapy or a switch over therapy, and what are the factors you will deal into that. Basically, it's the presence of fluid, activity of the membrane, and over a period of time, both response on the anatomical and functional outcome of the patient. The second part of my talk was on diabetic macular edema. Again, the question here remains is, are we at the panacea of treatment with the single anti-VEGF agents? And very happy to share the dais here with one of my first, teacher who started, we started with something on the SN dream. So Shankar Netralaya, diabetic retinopathy, epidemiological and molecular genetic studies. So we wanted to see whether beyond the ocular features, whether there are other contributive features which are going to be, these patients are going to get benefited in due course of time with treatment, or they become non-responders or recalcitrant. So when you look at the data, again here, the switching is been there in the practice for at least for 7 to 8 years, and people have switched over from one anti-VEGF agents to another anti-VEGF agents. Mostly the patients have been shifted from bevacizumab to ranibizumab to aflibercept, and shows a very good response. But over a period of time, what we have seen is the anti-VEGF agents have also evolved, and our understanding of and usage of these anti-VEGFs have been evolved over a period of time. And now people are trying to understand whether the brolucizumab works quite effectively well, especially in the cases who are non-responding or has a poor visual acuity at presentations. So the evolution of DME therapy still continues, and we are still learning with newer molecules at hand. Whether we want to classify the same definition which was given for neovascular AMD, yes, does it makes sense, but here the tachyphylaxis is not seen that much. However, we do see patients who are non-responders to any kind of treatment, and then try to think over whether you want to switch over or not. Certain giants have given definitions, as Phil Rosenfield also says that as good as one injection and you see no OCT change, that means it falls as non-responder, but we don't follow this. We follow a couple of standard protocols here. 3 anti-VEGF injections have been given of any drug, and no anatomical response has been seen on OCT. So this is the acceptable language or understandable terminology. However, there are people who have classified as functional response after 3 anti-VEGF injections. That also is an acceptable thing. And then no anatomic and functional improvement and increase in the size of the macular edema. So the response types can be lack of durability, partial responders, or a true non-responders. So this has to be looked into this. And DME is again a complex disease. There are multiple pathways apart from VEGF which interplay. So we are targeting only one therapy, and we should not just say, okay, we have the panacea of treatment and my patients are going to get benefited. DRCR.net has also given us a lot of insights over a period of time, especially the newer protocols like protocol T and also going on. And there are some head-to-head comparisons of treating aflibercept versus ranibizumab for treating persistent diabetic macular edema, and people have shown that switch over from one agent to other agent, especially the higher molecular weight, higher anti-VEGF agents, does really benefit over a period of time. The question remains is when to switch. So normally we classify at 2 or 3 injections. When you don't see an adequate response, then you try to switch over these patients. This is one of the standard available treatment protocol, but previously treated macular edema with multiple anti-VEGF injections, steroid injections, and lasers. Again, revisit and look at your diagnosis. If necessary, do an angiography and OCT again. And the major criteria here remains the OCT, and especially the OCT-A, how it's going to change the management protocol in the near future as well. So we have a case who is going, showing good response, a healthy case, keep re-injecting. Inadequate response in a healthy case, keep injecting every month, maybe for 2-3 months. If you don't see any adequate response, then you try to switch over between either of the agents. And eyes with have a bad visual acuity, that means a poor visual acuity at presentation, maybe beyond 618 or 624, go for a higher anti-VEGF agents rather than just trying with bevacizumab or ranibizumab. Elderly pseudophilics, we do have a choice here, or even in pregnant ladies and patients who had recent MI or stroke, straight away go with Ozurdex or IVTA. And diffuse DME, there is a combination of treatment available. In certain selected cases, we also tend to go for a vitrectomy surgery. So over a period of time, a lot of trials have shown this clinical data that switchover therapy in DME as well as works. Couple of patients which have been treated by us. This is a patient who received multiple injections, almost 11 injections of a couple of lower molecular weight anti-VEGF agents, and did respond. So then we shifted this patient to, after 2 or 3 injections, showed a very good response. Another case, this kind of a kind of a refractal hard exudate plaques, you think whether this patient is going to respond to it or not. But this patient responded over a period of time just with anti-VEGF monotherapy. People have also used alternative therapies like aflibercept and all. I don't have any personal experience with this, but our friends have used it. As Dr. Lalit Verma said, faricimab is another promising agent which is on the horizon. Brolucizumab again has been going to be recently available for us to be used for diabetic macular edema. But there are a lot of ifs and buts of using this particular agent in DME as such, per se, as a primary therapy or even a rescue therapy, though time will tell us. However, whenever we have a patient with DME, we don't, in current situation, we should be looking at and revisiting our diagnosis with wide field imaging systems available and presence and absence of OCTA. OCTA plays a very big role, has been seen by previous cases as well. And try to look and revisit your diagnosis. As this patient has a non-tractional PDR with DME, the management will change slightly as compared to a pure DME patient. And there is always a fine balance between under treatment versus over treatment. As you can see here is a wide field angiography image showing an early proliferative disease. And if you don't laser this patient is not going to respond to the treatment. We should congratulate Dr. Bhawankale also getting getting this kind of an image published on the cover page of Ophthalmology Journal, which is a very prestigious journal and a recent issue. So this is the way wide field imaging is going to change and OCTA is going to change our treatment protocols. Always fractional DME at any stage of the disease needs surgery. So what are the markers of good visual acuity in a nutshell? When you see a spongiform diabetic macular edema, you see an intact ISOS line, intact external limiting membrane, no subretinal fluid and no drill. So these kind of patients, they do fairly well with a couple of injections of anti-VEGF, and they tend to also get a good anatomical and functional outcome. However, when you have OCT biomarkers like this, the steroids become one of the first choice of treatment when they show an inflammatory response of the retinal surface. So the take-home message is we always tend to go for a combination therapy. You have a non-center involving macular edema, laser still has a role, that is a focal laser. Anti-VEGF can be started as a primary or an adjunct therapy and based on the case-to-case selection, and also give importance to the systemic parameters of the patient. To conclude, how do we change or shift over? We initially planned for 3 monthly injections, or at least 3 injections given at frequent intervals, maybe not be monthly, sometimes it can be a 2nd month or 3rd month. Then decides basically based on your clinical judgment as well as OCT biomarkers whether the patient has responded to your treatment or not. Switchover is a possibility in DME as well, and it really works. Laser for the non-center involving lesions. And we also need to consider the financial status of our patients. OCT at every visit, this is a standard norm at our practice, and it can be done quite easily. And OCTA is the making our understanding very clear and changing the treatment dynamics. Thorough clinical examination and understanding patient needs is also crucial in decision making, along with a good systemic control. Thank you very much for a patient hearing, and thank you once again for the kind invitation. Thank you so very much.
Thank you, sir, for a wonderful presentation. Any opinion from our panelists? Any comments? Okay, we'll move on to next topic.
Sir, I had a
okay, Sivan. Yeah.
Sir, in response type, when do we what is the reduction in the macular edema when we say that the patient is partial responder? Like what should be the percentage, or there is any cutoff to decide partial responder OCT's fluid?
So basically, you need to see what is a baseline, thickness. So suppose if the baseline thickness is somewhere around 400 or 450 microns, and you see the other features on the OCT. If there are no OCT biomarkers are seen apart from just a cystoid macular edema or central subfoveal thickness which has increased, with the one injection or maximum 2 injection, the patient should respond quite dramatically. If it is not responding, then you revisit and see what are the reasons for non-responder and then classify and treat it accordingly. So somewhere between 50 to 80 micron reduction, if you get that, considers to be a satisfactory response on the first injection.
Sir, am I audible?
Yes, sir.
Yes.
You told regarding diabetic macular edema in pseudophage elderly, we can switch over to IVTA. I have one question or one suggestion also. Can we give a titrated dose of IVTA 2 milligram 0.05 ml in such patients who are responding to multiple anti-VEGF injections? And can we give in the pseudophage around 60 years? So why elderly only?
No, it is just a general comment. It's not like elderly. We even give in younger patients as well.
Yeah.
Not even 60 years. So it is just a comment rightly pointed out by you. And definitely titrated dose of IVTS still works quite well, very well. In fact, we have tried with combination therapy also in the past, or where you are little, desperate, or you want to prolong the duration of the treatment, as in this COVID pandemic, you don't want to give monthly injections. So definitely steroids are becoming one of the most preferred choices in the management of diabetic macular edema.
Thank you.
Yes, Dr. Rajiv Raman has a
I just want to ask one question.
Please.
Sir, can we have any separation, or can we identify in diabetic macular edema cases that endothelial growth factor is more predominant or inflammatory component is more dominant? So we can choose the treatment option going for the steroid for the inflammatory component, and if there is a endothelial factor is more predominant, then we go for the anti-VEGF treatment. Do we have any kind of study available, or you can go for like that, sir, only?
Yeah, but so there are two factors which you look at it. As I showed one on the OCT scan, like hyperrefractive dot echoes, they tend to show more of an inflammatory response in diabetic macular edema, and also presence or absence of subretinal fluid. So though the house is divided on that, but whenever you have a SRF, we tend to go towards more of a usage of steroid rather than anti-VEGF agent. And also, if you have given 1 or 2 anti-VEGF previously and you don't see a very good satisfactory response, then it's a case of early switch over to steroid rather than waiting and watching for the improvement of anti-VEGF.
Okay, sir. Thank you, sir.
I think Dr. Rajiv Raman wanted to make a
just wanted to make a comment on the last question which was asked, that what should be the cutoff. So what you said is absolutely right, that one you can talk about is quantitative terms, but more than that, you can, first thing is look at central subfield thickness. Don't take the manual measurement. Second, the diurnal variation is 11%. So if you take a OCT thickness measurement morning, evening, there can be a variation of 10 to 11%. So anything more than 10 to 15% reduction is considered to have some response. So you can think of, if this reduction is 10 to 15%, say some response is there. So quantitative terms, except for those who have renal problems, because there the diurnal variations also become very high. So there you don't rely on this 10 to 15% cutoff, but all other cases that should be sufficient enough.
Sir, I would like to ask a query.
Please.
In diabetic macular edema cases, choosing in between steroid, especially I would put it as Ozurdex versus anti-VEGF, would it solely be on the basis of what would act better on the DME, or whether the disease is proliferative and versus non-proliferative? That will also be important in the decision making if we are anyway going to laser a proliferative diabetic retinopathy. So if we have a DME with hard exudates, massive fluid, but severe proliferations all around, would the decision of choosing steroid, which would be better in this diabetic macular edema, be the wise thing to do? Or because of the massive proliferations, despite we are lasering, but still anti-VEGF can be considered to be a better option in this situation? So my question is whether proliferations, a proliferative disease, also have to be kept into mind while choosing in between Ozurdex versus an anti-VEGF for treating the DME?
Manoj, you want to take or shall I answer?
No, please answer. Please go ahead.
So, yeah, what you are telling is absolutely correct. When you have proliferative component, it's better to use the anti-VEGF unless there is some tractional component which is there. So if you don't find a tractional component with the diabetic macular edema and PDR, traditionally we used to do a nasal PRP and leave, just do a macular treatment. But now the protocol J of DRCRNet very nicely, elegantly showed us you combine both. So these cases, I agree with you, anti-VEGF is important, but the situation which you told now, you have massive exudation, you have fluid and PDR, I will still go ahead with the anti-VEGF, but being these parameters, look into systemic parameters. Definitely he is having proliferative component, he has got a SRF, he has plaque of hard exudates, control that, and I would still prefer a anti-VEGF over steroid in these cases.
Any take about combining both steroid and anti-VEGF if the patient is affordable enough?
No, it is not affordability. The biggest query is we really don't know which did the magic. Because no, I would not tend to give him a risk of increased IOP, injecting steroid again and again. So I never combine, and definitely we tend to avoid that situation of combining both, because if response comes, because we know it is not one-time treatment. DME is not like you have to repeat these treatment and then always you will be combining both. Like you really don't know whether steroid worked or anti-VEGF worked. So I don't think that's wise to combine both in these.
We'll move on to the next
Move to
topic.
next talk. Okay. Okay. Next talk is on long-standing foreign body, and the speaker is Dr. Satyaprakash Tiwari. He doesn't need any introduction in our area. He's basically has done his fellowship, prolific VR surgeon, done his fellowship from Arvind Pondicherry, and the director of Drishtipunja Eye Hospital. So on to Satya.
Thank you, sir. Am I audible, sir?
Yeah, you're audible.
Thank you so much, sir, for kind introduction. And I'm extremely thankful to Bihar Ophthalmological Society and our CSC Satyajit, sir, for having me here to present this interesting case. It is a small case presentation. I would like to share with you all. If my slides are visible.
Yes, it is visible, sir. SPT, go ahead.
Thank you, sir. So, yeah, a 52-year-old gentleman, he was actually sent to me by a senior glaucoma colleague. He was having glaucoma for a longer period under treatment by various consultants and seen many times, and sometime 1, 2, or 3 anti-glaucoma agents were being given, and the disc was quite pale and significant cupping was also there, and periodically recorded high IOP and sometime controlled IOP as well. So currently he was on 3 anti-glaucoma and IOP was under control, but he wanted to do trabeculectomy. He saw something unusual over the posterior pole and he sent the case for just a clearance, that retina evaluation before glaucoma surgery. So the gentleman came to me for just a retina opinion, and his presenting symptoms were redness, burning in both the eye and defective vision in the left eye. There was no history of any systemic illness, and he didn't give any history of trauma since we didn't ask, and it was a quite long back history of trauma. He doesn't remember exact years also, but once we made a diagnosis and then we went back and asked him about the history of trauma, he did give a history of trauma while doing some chisel hammer work around 30-35 years back. And he has a history of some retinal laser treatment done around 4 to 5 years back. And previous medical record, there was a noting of barrage laser for some unusual pigmented lesion. Probably it was diagnosed as extramacular CNVM or something, and it was lasered elsewhere. On examination, there was a disc pallor and significant cupping. Yeah, and that I have already I think explained. On ocular examination, right eye was absolutely normal. The left eye was having BCVA 6/9 partial and intraocular pressure 22 with 3 anti-glaucoma agents. On anterior segment, the cornea was absolutely clear. There was an iris hole at 3 o'clock position and localized cataract just behind that iris hole. The fundus was of right eye was absolutely normal. Left eye, we could see this suspicious lesion and some old laser scar around it. This is not this is not any retinal lesion. This is just a scar. This is not any scar on the fundus as well. This is just backshadowing of that localized cataract. That localized cataract passed a shadow on the fundus, and fundus at this place is also absolutely normal. There was nothing abnormal here. Now we did a fundus autofluorescence, and we could see that hypo autofluorescence at the laser scar, and there was a hyper reflective area. Here we can see most probably due to fibrous tissue overlying that foreign body. We did an ultrasound B scan just to rule out what it is. At initial thought, even I was also thinking that is it some localized choroidal lesions, it is some metastasis or some tumor or whatever. But once after doing this ultrasound B scan, it was quite clear that most likely it is a foreign body behind in the subretinal space, because there was a clear-cut hyperreflective lesion localized and there was a backshadowing. We did ask him to undergo a plain X-ray orbit, AP and lateral, and we could see this hyperreflective, a small tiny foreign body here in the circle. So after doing all these tests, now we were pretty sure that it was a metallic projectile foreign body lying in the subretinal space in between choroid and retina. It was encapsulated and it is there for a longer period of time. On clinical examination, we could not see any sign of ocular siderosis, but definitely in that eye there was a significant cupping and disc pallor as well, and raised intraocular pressure. So what we advised to our patient that he should undergo ERG first. We didn't have ERG at our place, so we advised him to undergo ERG first and continue the anti-glaucoma medications. As of now, we advised him observation for intraocular foreign body. But just I have few questions for the panel and for the house, that how should we approach this case? A few things which came to my mind, few questions and query, is that if that glaucoma was due to, is it a secondary traumatic glaucoma, or is it some sort of siderotic changes localized to optic nerve? Is it one-time assault of optic nerve causing damage, or it is a persistent phenomena and this optic nerve change is going to progress if we leave that foreign body? Another thing is that can we, how frequently, if we don't operate this patient, how frequently should we do ERG for this patient? And should we consider any probability, or should we go ahead and remove this foreign body and make the patient free of foreign body? So these are all my points and questions for discussion. And now over to Saurav Sinha sir to lead this discussion.
Again, Dr. Saurav Sinha sir doesn't need an introduction. Basically, is a Don of West Bengal, and
he's Don of India,
and a teacher sought after. So on to Saurav sir.
Don में अच्छा है या खराब?
नहीं, Don है में अच्छा ही है. ये अच्छा वाला Don है sir.
I have one question. The whole presentation you don't mention gonioscopy finding. Was an angle recession? That would explain the trauma. A foreign body would cause an angle recession, but if there's an angle recession or there's an angle root, I think gonioscopy is not been mentioned. Tiwari? Satyaprakash, am I audible?
Lost connection. I think Dr. Tiwari has lost the connection.
He's there. Satyaprakash, you are back?
SP.
He's bringing the gonio slide.
Okay. So, would I touch a 30-year-old eye? No, I wouldn't operate on that. No way. I would love my glaucoma colleagues, Nilesh and gang, to look at the glaucoma part of it, do trap, do AGV. Retina to touch nahi karna hai isme, for no reason whatsoever. It's the laser scars there. You try to pick it up, you can cause a retinal tear, you cause lots of messy things, no touching the foreign body. Siderosis is not seen clinically. After 30 years, clinically, something you would see. Of course, I would wait for the ERG finding. I would be in no rushing hurry at all to touch this case at all. Leave it to the glaucoma. Tell the glaucoma people hold on for another 2 to 3 months. Ab tak 3 saal se chal raha hai, chalne do. Get the ERG done if possible, if the patient afforded, it's available for us. Definitely no intervention for the foreign body, talk about foreign body. He asked a very important question. How did it get missed so many times? I think we keep seeing old notes, and sometimes the retinal surgeons, we look at very cursory glance and sometimes miss these findings. So I would really recommend what we learned from this case from Dr. Tiwari and his group, that we must have very high suspicion. Anything which you don't see the notes very carefully. Ultrasound, OCT also there might have helped. If you're not very keen on doing an ultrasound, just the OCT, we are very trigger happy OCT nowadays. And that would be not a bad thing to do.
Where all glaucoma surgeons missing the iris hole for a PI?
I have no such comment to make.
Was there any PI present in this case?
No, it was iris hole. There was no PI.
Iris hole.
Iris hole.
Nobody made the iris hole.
But with the iris hole and a lentil changes, one should always suspect there is an injury.
Yes. Yeah.
And what he mentioned, there was a peripheral cataract adjoining iris hole.
Yeah, entry point is already.
Yeah. And I think there has already been a diagnosis of intraocular foreign body because the barrage laser is around that. It's not.
No, actually, what happens in this case, people whole attention shifted towards the glaucoma management, so they missed out the intraocular body. They couldn't even think of the whole attention. Otherwise, normal Dr. SPT.
So the one thing that is perplexing the whole discussion is why the patient has a unilateral glaucoma. That is the only
that's why I am asking you why nobody had thought about it. Anybody,
there could be a recession also.
The glaucoma department. We'll have a glaucoma meeting for this.
It has to be a secondary glaucoma, secondary traumatic.
Whatever foreign body, it is relatively inert. That is what we have to understand.
So I think the best case what Dr. Saurav has suggested, leave the retina thing and do a trabeculectomy.
This patient originally came to me from a glaucoma colleague and asked that he want to do trab. So should I advise him that okay, go ahead, do a trab?
I think what was the gonio features? With us.
So, sir, I didn't do gonio and I didn't see any previous record also because the patient came
important to differentiate a siderotic glaucoma.
Yes.
If you see a siderotic glaucoma, I think that's definitely indication of removal of a foreign body.
Sir, my question is, can isolated siderotic glaucoma be present without any changes in the fundus for the last 30 years?
No, clinically,
it might be because of
many times clinically fundus you won't see anything. ERG is important.
Yeah, ERG is important.
ERG. Yeah. So what happens? You get a supernormal response initially. But this is 30 years.
Sir,
very less response.
Sir, even if you remove the foreign body at this stage, you will need a trabeculectomy to reduce the pressure.
Absolutely correct. Absolutely correct. You have to do all those measures. But if there are siderotic changes, if you are seeing those changes which are there, definitely even after 30 years, you repeat ERG every 3 months. The changes do reverse.
Sir, isolated
will not increase.
Sir, isolated trabecular meshwork siderotic changes are reported.
Yes.
I mean,
not necessarily Abhishek, not necessarily siderotic changes. Even lot of pigmentation might have released, and that might have caused the trabecular meshwork to be clogged down and finally resulting into high pressure and glaucomatous changes. Even without radiation, you can get this kind of picture. But one thing is very critical: unilateral, this kind of glaucoma, one has to find out the secondary cause.
Can I just add one comment that? Can I just add a comment?
Yes, ma'am. Yes, ma'am.
Yeah. So I think the message should not go out that just we have to observe these eyes, because the patient is having a very distinct history of a metallic foreign body in the eye. And for 30 years, I think he's been lucky that he's maintaining a 6/9 vision. But I think surely we have to rule out that there are no early siderotic changes. Because, once clinically they start appearing, I think it's too late for the changes to reverse back of siderosis. So as was being discussed and as even Dr. Rajiv highlighted, I think ERG and doing a gonioscopy and ruling out any early signs of sidrosis would be mandatory. And if they are there, I think it surely would need a removal of the metallic foreign body, explaining the long-term complications of having it inside the eye.
Actually, yes, you rightly said, ma'am. Actually, the classical teaching is that any metallic foreign body should be removed, whether we don't have to wait for the cirrhotic changes to develop.
Yes.
Otherwise, once
Sir,
it's
sir, but the
classical
conflict here,
teaching in postgraduate day, I don't know.
sir, but the conflict here is that can a foreign body stand there for a 35 years with early cirrhosis? That is the conflict, sir.
Yeah, and if it
Maybe
is
there
well
is a chance if it
encapsulated,
is
then
encapsulated foreign body, there is a less chance of having cirrhotic changes in those
yeah,
cases.
if it is well
That is why facilitated.
encapsulated, then it may not cause cirrhosis even for years and years.
Yeah, but once it sets in, if you are going to do trab and all everything, there might be some change in your ocular dynamics that might again lead to cirrhotic changes later on. Maybe it is very unique case and very difficult.
We have to take into consideration that
And
there is a
the
radio.
patient's question, when I discussed with him the probability of removing the foreign body, he asked that कि सर हमको फिर दवा नहीं ना डालना पड़ेगा ग्लाकोमा का 30 साल से डाल रहे हैं. Then I told कि no, you don't think that if I remove the foreign body, your glaucoma is getting cured with removal of this foreign body. In fact, suppose if there is a retinal break and we put on silicone oil, that may add on the complication of having increased IOP and are difficult to manage that glaucoma as well. So that is another point.
Thank you.
Okay, we'll move on to next talk.
The next presentation, please.
Yeah.
Paucity of
next,
time.
Next presentation is by Dr. D.G. Chakravarti. He will be talking on Braille study, brolucizumab in neovascular AMD. He is a senior consultant at Disha Eye Hospital and has done his fellowship from SN Chennai. He has done additional training in ROP and is a reviewer of different journals and has a publication in peer-reviewed journals. He is principal investigator in many trials. So on to Dr. D.D. Chakravarti.
Thank you. I hope my slides are visible.
Yes.
Yeah, I'll just go full screen.
Full screen.
And I'd like to thank BOS for this kind of opportunity here this evening. And it's nice to see many of my friends and seniors. Warm regards from Disha Eye Hospitals. I'll be speaking on the Braille study, brolucizumab in neovascular AMD in Indian eyes. So we all know that we have brolucizumab, the new kid in the block, and kid in the true sense that it is actually a very small molecule of 26 kilodaltons, and it is
cut it down.
It is one of its kind single chain fragment antibody which allows a deeper penetration into the retina, faster onset of action, greater molar dosing is possible because of this, and also it is supposed to cause lower systemic concentration of the drug. Now we've all come to know about Hawk and Harrier so far, and well, basically with visual acuity, there was not much difference with aflibercept, but when the deep learning based OCT analysis results came out, it was noted that there was extensive decrease in intraretinal fluid following the first dose of brolucizumab. So also superior SRF resolution with brolucizumab, and also more pronounced PED resolution was noted with brolucizumab. Now, since its advent, there have been multiple real-world publications, and the only thing that was lacking was some Indian published data, and so we this is something that egged us on, and something that is very similar in all these studies and real-world data rather is that there is superior fluid resolution that has been noted with brolucizumab, and increase in treatment interval has been possible with brolucizumab. So the Braille study, basically the purpose was to assess short-term efficacy and the safety profile of intravitreal brolucizumab in Indian eyes with neovascular age-related macular degeneration. And this was patients with visual impairment due to neovascular AMD. This was multi-center, retrospective, consecutive, interventional, uncontrolled, non-randomized study incorporating data from 4 tertiary care centers in Eastern India. And so basically we had 94 eyes, of which there were 20 naive eyes and 74 switch patients. And these patients were on a strict PRN regimen with very strict follow-up. They were followed up at day 1 following the injection, and 1 week and every 4 weeks thereafter. And we try to evaluate change in visual acuity, SD-OCT parameters, short-term safety of brolucizumab in Indian eyes with neovascular AMD. So moving straight to the results. Now, this was predominantly a male cohort that we were looking at, and the mean age of 67 years. And in the patients who actually switched over, they had a mean of 8.63 injections prior to going into brolucizumab. The mean number of brolucizumab injections that this cohort received was 1.36, and the mean follow-up was 7.3 weeks. The range was between 5 and 30 weeks. And what's interesting is that the interval between the intravitreal brolucizumab injections was 10.2 weeks. So what about visual acuity? Well, if we talk about the full cohort, the visual acuity improved from 2120 to 2093, which was statistically significant. So also was the central subfield thickness in the full cohort. From 408, it came down to 281. And if you talk about the fluid characteristics, subretinal fluid resolved in 15% and reduced in 78%. Intraretinal fluid, which is something that we are all kind of scared of or we don't like, 40% got resolved and 46% got reduced, and PED 23% got resolved and 61% was reduced at final follow-up. Now, what about the subgroup analysis? When we talk about the switch patients, basically from 2158 at baseline, they improved to 2004, which was statistically significant. And if you talk about the switch subgroup central subfield thickness change, from 410 at baseline, they improved to 280. What about the naive group? Well, here you can see from a baseline of 2064, they improved to 2050, an improving trend. But here you can see a little bit of the ceiling effect kicking in, and the central subfield thickness in the naive group, it improved from 398 to 285, which was statistically significant. Just to show the cases that were highlighted in this article. So this is a 64-year-old naive lady with a large SRAM and subretinal fluid. So this is just 1 week post brolucizumab, and you can already see the SRAM melting up. I saw a couple of cases by Dr. Manoj Khatri, who also showed SRAM melting up. And this is at 8 weeks following the first injection, vision improving to 20/60, and then this is at 12 weeks. So here you can see a little, I hope this is visible, little speck of heme coming back. And so the OCT also looked ominous, and we went ahead with the next injection. And actually, this is 12 weeks post the second brolucizumab injection. Patient is doing 20/20 part, and there's no fluid. So basically, just to quote Hawk and Harrier, more stable inactive lesions in the subretinal space where the CNV localizes is what Hawk and Harrier told us. So moving on to the next case, this is a patient who's had 11 anti-VEGF injections prior to going in for brolucizumab, and this is the subretinal fluid that's there. Intraretinal fluid is also, seen here. Some amount of hyperreflective foci also you can see, and this is the OCTA at just prior to brolucizumab. And just 1 week post brolucizumab, you can see there's improvement in the SRF. It's getting decreased. This is 1 month post the brolucizumab. You have a little bit of SRF left and a little bit of intraretinal fluid, and it improved till 16 weeks when actually the intraretinal fluid came back. So you have evidence of a greater molar dosing causing longer duration of action with this drug. What about what happened after the second brolucizumab injection? Well, look at the retina, it looks nice and neat. And this is at 3 months. You can see maybe a little bit of fluid coming back here, and this is what happened at 4 months. So you have intraretinal fluid coming back, subretinal fluid coming back, and this is when the patient got the next injection. Now, like in this Braille study, the other studies all have shown that there is a significant improvement in the SD-OCT characteristics when it comes to brolucizumab. But when it comes to the improvement in vision, though all of the studies have shown an improvement in vision, the REBA study and the Braille study had significant improvement, while others showed improvement, but there was statistically, it was not really significant. Probably what actually happened here is, like I showed in the naive subset, the ceiling effect probably kicked in. And basically with our patients is the baseline vision at which we generally tend to start our treatment of our patients is in fact lower than in the West. So the other important thing that we noted is, like the studies have mentioned, brolucizumab is a durable agent, and we noted a mean time to next injection of 10.2 weeks. Remember, we used a PRN regimen. What about adverse events? Well, we had RP rip in a patient from this cohort. We had 2 subretinal hemorrhages, and the RP rip we actually went on to publish in the Indian Journal of Ophthalmology subsequently. So inflammation is something that has been reported with other anti-VEGFs as well. And we all know that racial and genetic differences in inflammation is something that we are aware of. And based on our preliminary results, so this is something that really needs to be investigated, like Lalit sir was also mentioning, that whether it's the genetic thing that is something that actually needs to be looked into, which we have published. And we also actually have published 3 other articles, all on PRN regimen. And we actually haven't had any inflammation in these, subsequent series also. Now, this is for diabetic macular edema, these 2, and this is in PCV. This is just about to be published. The final proofs have come in the Indian Journal of Ophthalmology. This is regarding PCV. Of course, the study had limitations for retrospective, limited sample size, a very brief period of follow-up. We used a PRN regimen, unlike what Hawk and Harrier would tell us. And the study was also not powered for a safety analysis. But to conclude, early real-world Indian evidence suggests that intravitreal brolucizumab is safe and efficacious in the treatment of neovascular AMD, and including patients from various ethnic backgrounds with a diverse genetic pool is critical in determining the putative role in mediating brolucizumab-induced IOI. Just before I end, let me share that we've used more than 950 vials of brolucizumab at the eye hospitals and for various indications, mostly neovascular AMD, but also recalcitrant DME and some recalcitrant RVO. And we've had fairly good results. Thank you for your kind attention. I'll stop sharing.
Thanks, Dr. Chakravarti. It's a beautiful presentation, and thanks for compiling that result across multiple sites. I think it was a multicentric study involving about 3 to 4 centers.
Right,
a good study. I have only a few points about it. Again, the first thing I would say is your definition of recalcitrant. In the article, it mentions 10% reduction, I think. You didn't take into account number of injections, because if you see your average injections, you said 8.6 plus minus 4.7. That means even with a 3 injection, it was called as recalcitrant. It is something not universally accepted in the retina community. The second thing, I just wanted to know, you had a follow-up of 1 week, 2 week, 4 week, and 1 month. That's what the article says. How many of them followed all 4? It was very difficult to have these 100 patients coming for 1 week and 2 weeks. Well, 4 weeks is absolutely fine.
Right. Actually, since this was a retrospective study, we only picked up those patients who actually followed the perfect,
so good, because that is something which is a very big problem, and why I was keen to know that many times. So you have 2 domains of intraocular inflammation. One domain happens in the early stage, which is usually with other anti-VEGFs also, which you can pick up only in this 1 week, 2 week. So I wanted to know if any loss of follow-up. That is the reason I asked you, because that's important. The second thing is your follow-up is 7.3 weeks. Average follow-up minimum is just 5 weeks. Okay, so if you look at intraocular inflammation reported outside, the average duration is about 25 days. That means about a month, so until 6 months. So probably we are catching, your study is a good study to show early efficacy, showing that very good durability. It works well, absorbing all fluids, drying the retina well. But definitely, I would not say anybody should take a take-home message that it is safe. Because as I told you, it's only 25 days. No, is the majority of the studies found the average time when this side effect happens is 25 days to 6 months. And this was quite early. One of the patients was only 5 weeks follow-up. It does give us an idea about durability and the dryness, but I'm afraid it doesn't tell much about the safety of the drug.
So Devdutt, offhand 950 injections, how many reactions?
We have had 3 reactions. 2 of them basically.
Rajiv, I think that's an important number over there also.
Yeah. Yeah.
No, I'm talking about only Braille study. 950 is
No,
the data. Yeah. Braille
yeah.
study. But yeah, I agree with you. What you're telling,
So,
953 is a
you
good.
have to combine real world data with, I agree with you. The real advantage, the problem with practicing in Chennai and Shakaratana is you can't get a patient to come back 1 week, 2 weeks, 4 weeks. We here in Calcutta can. They are very close to us. This is one advantage for us to do these studies.
Yeah, no, it is a good molecule. Definitely, it is a very good molecule.
And
Only
950 is not a
issue,
small number.
the
I
only
think
issue
what
which I have,
one thing that I need to mention here is that this is an initial experience that we published.
I
We
agree.
don't
That's
want
a
to,
beautiful
you know, we don't
yeah.
want to like kind of portray this being safe, because if
I
you saw my
agree.
concluding
That's
slide,
what it's a.
it's not
efficacy.
powered for
Yeah,
a
I
safety
agree.
analysis,
I
and
agree.
none of the studies basically are powered. The anti-VEGF studies that we come across, these are not powered for safety analysis. So you need to have large numbers, which actually we have done for some other molecule. I'd rather not name it here. And we've had a volume of 9,000 injections. So we've commented about safety in that. So this is a study which did not comment about safety, and we specifically mentioned that this is not good enough to kind of talk about safety. But we were looking into early Indian
Efficacy.
experience, which
Yeah.
was not available, and that is what we intended to publish. And we
Beautifully
hope we'll be able to present the 1-year results of the Braille study, which is coming up shortly. And the 950 eyes that we've injected at Disha tells its own story. And we've had just three inflammations. And I think what I'm privy to some information which I think I can disclose from some of the studies that have, I would rather not name them, that have been done in the West. And what I've seen is that there are a lot of cases with suspect kind of fundus images, let me keep it at that, which have actually been injected with the anti-VEGF. So what happens is you don't know what you are dealing with. So when you treat a patient of neovascular AMD which has some other issue going in the fundus, which is picked up, which can be seen on the fundus image of those patients, so you really don't know what you are dealing with. So this could be a drug-related event, like Lalit sir mentioned. It might not be a drug-related event. So I think with time we are getting more experience with this drug, as with other drugs, as with the biosimilars also. And I think the jury is still out.
Dr. Chakravarti, I would like to congratulate you for this Braille study, which has been done on the Indian patients in neovascular AMD.
Thank you, sir.
The conclusion part, it is very important. You have said that a 1.36 injection is required per 6 months. That is nearly 130 days. At the interval of 130 days, we need to give one injection. That is
Sir, if I can correct, sir.
Yeah.
The mean number of injections was 1.36 in this cohort. So
Yeah.
we don't mean to say that for 6 months you need 1.36 injections. The mean interval between injections we calculated was 10.2 weeks. So I think there's a little bit of maybe I was not clear with that. So it is
Still,
10.2 weeks to the next injection.
Still, it is very important information so far as Indian patients are concerned. Do you have any study regarding the PCV patients? All your study is related to neovascular AMD. Did you
Sir,
do any?
Sir,
Yeah.
yes, sir. Sir, actually, this study was for neovascular AMD, but soon in next couple of IGO issues, I think our study on PCV is going to come up, and that's also a multi-center study. And that's basically up to 6 months. We have follow-up of up to 6 months in PCV eyes. And I think you'll find it interesting, sir.
Yeah. Thank you.
Thank you. So we'll move on to next talk. Next talk is on case series on brolucizumab in AMD and PCV. The talk is by Dr. Kshitij Kumar. He is basically a vitreoretinal surgeon at Disha Hospital, Kolkata since 2018. He has worked for 7 years in Agarwal Eye Hospital, Chennai. He has completed his VI fellowship from LV Prasad, and he has done this post-graduation from Delhi. He has published 23 publications in his name, both in the peer-reviewed national and international journal. And to his credit, he has pioneered a modified technique for closing lamella macular holes and has published the first original study and paper from India. So on to Dr. Kshitij for his talk.
Thank you, Dr. Vishal. Am I audible?
Yeah, you're audible. Yeah, you're audible.
So thank you for a very nice introduction and a kind introduction. So at the outset, I must thank Bihar Ophthalmological Society, Dr. Satyajit Sinha and Novartis for giving me an opportunity to share my clinical experience with intravitreal brolucizumab. So I'm a consultant of Novartis for this presentation. And briefly, going back to the brolucizumab molecule, by now everyone is pretty has got fair knowledge about what this molecule is. But again, just a brief revision. So it basically stands for single chain variable fragment, and it is the smallest antibody molecule till date. So if we look here, the full length monoclonal antibody. So it has two arms. It has two parts of the Fc portion and a Fab region. And in the Fab region, there is a variable light chain, variable heavy chain with the antigen binding site. So this is a representative of bevacizumab molecule with a molecular weight of 150 kilodalton. And if we just take one arm of the Fab region, then it becomes the ranibizumab molecule, which has a molecular weight of 48 kilodalton. And if we just take the variable light chain and the heavy chain and link them with a peptide linker with the 6 antigen binding sites, then it becomes the brolucizumab molecule. So going a bit more into the detail. So in the last decade, the research went into the pharmaceutical engineering for development of this single chain variable fragment scaffold. And onto this scaffold, these antigen binding sites of the variable light and heavy chains are grafted, resulting in the formation of the brolucizumab molecule. So what advantage does it offer is because of its small size, non-crystallizable, very soluble molecule, there's an increased bioavailability, reduced immunogenicity with a better target tissue penetration, greater focal efficacy, better durability of the effect, as well as low systemic exposure, making the molecule overall very safe as per this paper. But yes, we do have incidences of intraocular inflammation. So if we look at the spectrum of the anti-VEGF molecules over here, from ranibizumab to bevacizumab to aflibercept, the fusion protein, then the aflibercept, and then we have over here the cordyceps and the brolucizumab, which is the smallest one. So what it offers is, because of this small structure, there's 11 times more, 22 times more anti-VEGF binding capacity as compared to ranibizumab, and again 11 times more anti-VEGF binding capacity compared to aflibercept, and thereby and this is happening because of the higher molar concentration, that is 11 molecules per injection which gets injected. So briefly touching upon Hawk and Harrier, these were two similarly designed phase 3 trials comparing the effect of brolucizumab versus aflibercept to treat neovascular AMD. So many people have get confused, what is this Q8W and Q8W or Q12? So as per the treatment arms, so after the initial loading dose of at 0, 4 weeks and 8 weeks, then as for the aflibercept, the injection was given every 8 weeks, so that is Q8W, and for brolucizumab, it was given every 12 weeks. So the next injection would happen at 20 weeks. But the initial disease activity assessment would happen at 16 weeks to match with the aflibercept. And if the disease was active even in the brolucizumab arm, then from Q12W, it would be shifted back to Q8W, that is every 2-month injection, and then it would remain fixed for the next 96 weeks. And this Hawk and Harrier study basically established the non-inferiority of brolucizumab versus aflibercept in terms of letter gain, which we can see that 6.6 and 5.9 letters at 48 weeks and 96 weeks, which was comparable with the aflibercept. So coming on to my case series, my real world experience of brolucizumab in Disha. So this patient had been injected 3 doses of Accentrix for the CNVM in the left eye. The vision was stabilized at 6/24. Then the patient came back in 2021 with a new onset CNVM in the right eye, which was type 2 CNVM. And we can see the subretinal fluid with some amount of subretinal hemorrhage. The vision had dropped to 3/60, and patient wanted the best. And we offered the injection brolucizumab. And we see at 1 month and at 3 months with a single dose of brolucizumab, there was a shrum formation with reduced flow and completely dry macula with vision recovering to 6/80. So on 3/3 millimeter octa scan with a choriocapillaris segmentation, we can see a beautiful neovascular front, which had, however, was not very active. So moving on to the case 2, now this patient had a type 2 CNVM, and he had been injected with 5 injections of Accentrix between 2018 and 2019. And again, the patient came back in 2020 with the CNVM character changing to type 1 CNVM, and there was a fluid, and the patient received further 6 more doses. But even with the Eylea and the last dose, the fluid was persistent. So the patient was switched to injection brolucizumab, and with 1 dose, we can see that at 1 month, the fluid had completely disappeared, and this was maintained even at 6 months with a completely dry macula with a single dose of injection. And on OCTA angiography, we can see a very sparsely dense neovascular front, and on the choricapillary segmentation, we can see that there was a reduced flow. So with this, we move on to the another spectrum, that is the PCV of neovascular AMD. So this gentleman had received 12 injections, 9 Accentrics and 3 Eylea between 2019 and 2021. And we can see even after the last dose, there was a chronic IRS with a fibrovascular PED in the right eye. In the left eye, there was a notch PED with SRF, and the vision was 5/60, 6/24. The patient was very upset with his visual status. So before I go on to the treatment, I just trying to highlight that even at times, sometimes the octa, if we do a proper segmentation, can reveal the polyps and the branching vascular network. Though I'm not advocating it that it should be done for every PCV case. So if you see here that when we do the segmentation at the choriocapillaris level through the double layer sign of the complex, then this structure stands out to be the branching vascular network. And when we move the segmentation a bit higher through the PED, just underneath that, the NFAST image reveals the polyp, which has a hypolucent center with a hyperreflective ring. And there was another polyp adjacent to this complex, again highlighted by the NFAST image as the polyp structure. So this patient received brolucizumab in both the eyes. And at 1 month, we can see that the shrum was flattening in the right, the fibrovascular PD was flattening. And at 3 months, there was a shrum formation with a completely dry macula and the vision recovering to 6/36. In the left eye, there was remarkable recovery. It was never so dry, and the PED had flattened, the fluid has resolved, the vision had recovered to 6/9. Even at 5 months, the vision was well maintained with a good macular anatomy. However, the patient came back in the 6th month with a rebound or the recurrence of the fluid. And again, I injected a second dose, and at 1 month, again, a beautiful recovery of the foveal and macular anatomy happened. Moving on to another case of bilateral PCV. Now, this patient again had received 8 injections post last dose of razumab. The right eye had extensive exudation. We can see the tall PED with extensive exudation and SRS, and even the left eye had the PEDs with the SRS, and the patient opted for brolucizumab at 1 month. We can see that the exudation had started to come down. The fluid had resolved. In the left eye, there was remarkable recovery to 6/12, and the patient received 2 injections at 6 weeks interval, and at 3 months, we can see that the macula was almost rid of the hard exudates with the flattened PED and shrum, and the left eye was maintaining a beautiful vision at 6/9 with a good recovery of the anatomical contour. Now, coming on to a more severe case now, when we see such tall PED with SRS, we are very scared because we know that with any of the anti-VEGF molecule, they can be a RIP. But however, the vision was very poor. I had nothing to lose. So I offered a brolucizumab injection at 1 month. With first dose, we can see that the PED has started to flatten. The SRF was resolving. And post second dose at 3 months, there was no RIP. There was a completely flattened PED and a shrum formation with marginal recovery of vision to 5/60. So with this experience, and I got a little emboldened. And in this case of straightforward tall PED with SRF, with 2 doses of injection, we can see a beautiful anatomical as well as functional recovery. And both these patients were lucky in not having the RP RIP, as shown by Dr. Debilal in one of the cases. Brolucizumab in such PEDs, RP RIP may happen. So moving on to the last case. So now this patient, this gentleman had a primary open angle glaucoma, and he presented with a notch PED with a subretinal heme as well as a sub-RP hemorrhage over here. And ICG as well as the angiography revealed the polyps. And I went for pneumatic displacement with C3 gas with injection brolucizumab. And at 1 week post-op, we can see that the hemorrhage had started to displace. And at 1 month, there was a resolving retinal heme. The subretinal heme had displaced downwards. There was a flattening of the PED, some chronic IRF, and by 4 months, since he was a known case of POG, I did not become very aggressive and just let the patient to recover. And by 4 months, we can see that the PED was flattened shrunk formation and visual recovery happened to 6/80. Thank you for your patient hearing, and open for discussion, suggestion, and comment.
Thank you, Kshitij, for a nice presentation. Now I'd request Dr. Prashant sir for discussion. He's a known figure in Nagpur, a prolific VR surgeon from
I think
Nagpur.
we're getting
and-
late. Everyone knows.
Yeah,
me. Thank
yeah.
you.
And one more, always a smiling face. VR surgeon with a smiling face. Always.
Thank you, Vishal. I think wonderful cases. Those were, in fact, type 2 and the PCV cases. We all have experienced the similar results with it. But in all your type 2 cases, initial 3 cases which you presented, you just needed 1 injection and that's it. And how long was the
But
follow-up?
the patient, luckily, see, I can't generalize that these patients would be requiring only 1 injection. But luckily, those 2 patients, because I have many more patients who required more injections. But as I showed you in the PCV cases, I had to go for 2 or 3 injections. But yeah, the neovascular AMD patients, I found that the drying effect was quite good, and particularly in those 2 cases when we got a 6-monthly dosing interval.
So you had a disease-free interval of more than 4-5 months.
Almost
how much was
more
the
than
maximum?
4 to 5 months. Yes,
So
more than 4.
what's your average duration which you get with a CNVM type of a presentations with the injections?
The disease-free
interval? Yep.
I would say around 4 to 5 months.
That's
Because,
great.
4 to 5 months, particularly in the CNVM case. So today also one of the patients came back, and I had injected in June. Now he's to undergo another dose.
So you have been practicing the means directly the PRN basis, just inject and follow it up. So you do see the patient after about say 48 hours, 24 hours, or what is your protocol?
I see at
because of
1
the fear
week.
of it. Yeah.
I see at 1 week, and thankfully in Disha we have optos, and I generally do optos in all the follow-ups because to pick up peripheral vasculitis, because most of the intraocular inflammation and maybe in the form of sheathing, even a small sheathing, you may miss on indirect sometimes in the OPD. So generally I send for optos, and then at 4 weeks, 1 month, 2 months, and then between 3 to 6 months, 3 to 4 follow-ups.
So that's a point of debate, I believe. Would digital photography replace an indirect ophthalmoscopy according to you? You don't do an indirect ophthalmoscopy for all these patients?
I do myself also, as well as for documentation purpose. And particularly in the optos, the technician, what they at times they pick up lesions sometimes which we miss in the periphery, because they use a magnification aspect of the optos software, where they can highlight each and every portion of the retina in detail, which I am not. I only go afterwards after the lesion gets highlighted.
We would have comment from the Don, Dr. Lalit Verma, about replacement of a indirect ophthalmoscopy with a wide field angio.
You see, I also mentioned that I also do slit lamp indirect and photography. The purpose of photography is to convince others that there is no inflammation. Because indirect is for my own this thing. I will definitely do a meticulous all follow-up visit. But photography is done to, objectivize whatever I'm talking about. Because in Devulal was, I just joined late when Devulal was finishing, that some of the case selection in the West, there may be, you see, if there is a slight media haze, photography will never be as good as your published in ophthalmology. You see, I was praising this thing. Ophthalmology, two front covers, excellent photograph. But if there is slightest inflammation, the clarity will be missing. So I just wanted to make, a couple of comments before, this long webinar conceived by boss Pranav Ranjan and Satyajit comes to an end. You see, Pagenax is not a panacea. Nobody is claiming that it's a panacea, but it definitely is a magical bullet. There's no doubt about it. Because I would, I do not have as much experience as Disha, as Kshitij and other people. But what I had concluded was, or maybe some impressions were, that specifically for occult membranes, specifically if there is a lot of SRF, specifically if there is a lot of sub-RP fluid with a PED or PCV kind of picture, it works like magic. But if there's a type 2 kind of CNVM, I would try with the aflibercept and ranibizumab. But these three indications for me, especially in people who are not responding, they definitely become an indication for brolucizumab. And regarding IOI, inflammation and vascular block fear, which the entire retina community seems to be having, you see, like Rajiv was telling, these studies have to be powered enough for, and the number of patients have to be huge. And for that, I had proposed to Novartis also, and I'm keen to collect data nationwide. You see 9,000 patients or nearly 10,000 patients of patients injected. Let us all collate on a one-page performa and see for ourselves. And then I think we'll come to some conclusion. And PRN should be the modus operandi as of now, and Q10 or Q12 is the best kind of dosing. That is the, like Rajiv and Khatri was also talking about, especially this COVID era, we do not need to rush Q4 or Q6. It's definitely Q10 or Q12 in all of my patients. And whenever SRF is huge and sub-RP fluid is big, a lot of sub-RP like Kshitij was showing, I think there's a normalization of that contour, except for unlucky patient who may have an RPA rip that nobody can predict, but it works like a magic bullet, and you see normalization of the contour, which Kshitij also showed. So with this, I think we should thank Satyajit, Pranav, and all these people. Must be tired, long day. And one thing I must compliment all the boss people. They are really the boss primarily because the number of participants I have been seeing is running to 3 pages of this screen, which has been, hi Saurav, how are you? So, and was tremendous. And I agree with Saurav that there's no indication for remove that formality at all. You see 6 by 9, 30 years, don't touch it. If it is my eye, I will not allow even any master surgeon to also touch it, whatever he may promise. And gonioscopy, I think, was missed definitely because angle recession has to be ruled out as secondary glaucoma. Because that is what will clinch the diagnosis. And wonderful job done, Satyajit, Pranav, and all the.
Thank you, sir.
Nagender. Thank you, sir. Excellent, Vibhuti. Great job done. And
thank you, sir. Before we close, I would like
thanks for closing remarks, sir.
I'd like to request our president, Dr. Pranav Ranjan, sir, to please say a few words.
At the end, I would like to thank everybody. 9:30. This is dinner time, and everybody has been there. 3 pages as described by Dr. Lalit Verma, sir. So I thank Dr. Prashant. I thank Dr. Kshitij, Dr. Chakrabarti, Shivendra Sahai, Dr. Rajiv Raman, everybody present here. We had a very nice day and very fruitful day, and even a non-retina surgeon has become a retina expert now. So thank you so much for giving us time.
Okay.
Thank you, sir. I would like to request
many
Dr. Vibhuti
thanks,
Prasad
everyone.
to please say a few words.
Thank you. Many thanks, everyone. Thank you.
Thanks,
Dr. Vibhuti,
Thank you, everyone.
Manoj.
Thank you, everyone.
Dr. Vibhuti, you are muted. Please unmute.
Novartis people need to be thanked, Farah and everyone. Thank you, everyone, and thank you all the participants for attending this webinar. And wonderful work by Satyajit. Thank you.
Thank you so much. On a Saturday night, we had almost 80 delegates at one point of time for a retina meeting, which is quite a blessing and success. I would like to thank Dr. Lalit Verma, sir, who is the president-elect of All India Ophthalmic Society, and he will be installed in Mumbai. Thank you so much, sir, for being with us right till the end. I would like to thank Dr. Manoj Khatri, sir, who gave the keynote talk also. I'd like to thank all the national faculties, Dr. Saurav Sinha, Dr. Everybody who was here tonight with us. I would also like to thank our president, Dr. Pranav Ranjan, for encouraging us, and Dr. Vibhuti Prasad Sinha for always supporting us in our programs. I'd like to thank Dr. Prashant Bhavan-Kule also for being here with us, and all the presenters who were with us this evening, especially Dr. D.D. Chakrabarti and Dr. Kshitij also, who made a wonderful presentation. I would like to thank Dr. Neha Kant and Dr. Vishal Kishore, who did a wonderful presentation, moderation for this evening. I'd like to thank all the chairpersons and all the expert panel who were here this evening to make this evening a wonderful success. Thank you so much. And once again, a big thanks to Novartis also
Keep
for this.
keep up
Thank
keep
you
up
so
the good
much.
work. Keep up the good work under the presidency of Pranav Ranjan. And I like that idea of having basic and clinical as a joint exercise will be wonderful. So bye and good night to everybody.
Bye.
Thank you, sir.
Good night, everyone.
Thank you.
Good night, sir.
Bye,
Good night.
Prashant.
Good night.
Good night. Good night. Good night, everybody.
Bye bye.